About the study.
Oh,
Okay. Can you hear me?
yes.
Okay. I'm really interested in the study that is looking at executive functioning.
Yeah, right. Me too.
Now, are you? Did I miss? Is that being done at Albany?
Yeah, so the Proof HD is ongoing, and so we're a site for that. And we're about to start for Sage, which is the one for executive functioning specifically. So we will be a site for that as well.
Because that, to me,
that's everything, right? Well, part of everything.
It is a part of everything, even the anger and all of that stuff, you know?
Yeah, I think that it's, I think a lot of times we focus on what's outwardly obvious, which is the movements. And the movements are annoying and they're maybe embarrassing potentially, but I think the thing that really sort of affects our day-to-day function, behavioral stuff can do that, but really it's cognitive stuff, and how much behavioral stuff might stem from frustration because things aren't as easy to do as they were before, right? And so I think studies that focus on how to either slow that down, or I think improving is a really big goal, but to slow that down means we can remain independent or semi-independent for a lot longer.
Mm-hmm.
Mm-hmm. Yeah, I agree, Kathy. I'm excited about it.
Mm-hmm.
The thing that's also interesting but / frustrating maybe for everybody is a lot of those studies that are focusing on disease modification in any way are recruiting earlier staged patients. And so it makes sense just from a practical view in that it's easier to measure symptoms once you start being a little symptomatic. It's easier to measure the rate of symptoms. But I think the key will come sort of how do we help at every stage of the disease? And I think Dr. Mulhall had a slide there saying that at some point, therapy is going to be targeting people before they're symptomatic, and that will encourage earlier testing. A lot in past education days, we've talked a lot about whether to test, about it being a very personal choice, and it still is, but what does it change? And so potentially it changes a lot, sort of with the way these studies are going and the information we're learning from them.
Yeah, just over the course of us being in the disease, the whole testing issue has really changed. It's from when you were first considering it to now. It's really kind of flipped it. So
I think that's right. And I think part of our number of new patients in clinic in the last few years reflects that. We don't normally have that many new patients in a 2-year period, and I think it's because of the hope and of what our research is telling us.
Mm-hmm.
Okay. Carissa, how are you doing?
All right, I'm doing great. Did you want to take some time to do any more questions? Because we can actually go until 10:15. Otherwise, we can go ahead and transition, but we will have to maybe take just a couple minutes to pause.
That's up to you. I don't, it doesn't seem like there are other questions.
Okay. All right, so we're going to go ahead and just pause for a couple minutes. We're going to try to help somebody get their screen up. We are shortening Julie's presentation, so we're looking at a new agenda. So we're going to restart at 10:15 with Victoria. Victoria is going to go for about 45 minutes and allow for Q&A. And then we're going to transition into 11 o'clock with Julie, and she's going to do some Q&A as well, and then we'll have our break. So I'm just going to hit pause for a few minutes, and we'll be right back.
Something positive, if there's something positive that came out of it, maybe that's worth sharing.
Yeah, always, for sure. We have I don't know that, again, I think it requires some thought. I think that sort of the way we were impacted by COVID is everything sort of scaled down. But it forced us to think about ways to do multidisciplinary remote visits, which we didn't explore during the peak of COVID. But I think all in all, we really were not as hurt by COVID as I think some of the larger centers, partly because, you know, our city's not so big and we've done pretty well, but I think also just because the way we've been able to sort of maintain appointments, right? Like we've been able to sort of pivot virtually, at least for physician appointments, pretty easily.
Well, that's to your credit.
Well, not so much to mine, but I think the impact of COVID, sort of from a bigger perspective in all of our, like all of what we do, but particularly in neurodegenerative diseases, I think that is something that all of the centers of excellence have focused on. Like in HD and PD, the restriction has led to like some predictable changes, but then some unpredictable changes too. And so how do you know, I think we rely so heavily on unintentional socialization, right? Going to the store, going to a restaurant. And when all of that was taken away for a brief period of time, sort of people had a harder time transitioning back to doing it, and sort of what was the impact of all of that. So that's been interesting.
Yeah.
But yes, I will send you emails on Monday for sure. And we got recorded, so it's like, right, recording is happening now, so it's, I'm held to it.
Yeah. The button is red.
Yeah, that's right. We're being recorded, but there it is.
It'd be great on the replay. 10 minutes of pause.
That's right. Oh, I don't know if you mind me talking about it. You can tell me, but Chris and I were at Ferncliff yesterday, and Charisse was out and about, needed help with her socks on, but was pacing the hallways. And I haven't seen her outside her room in years, and so it was lovely.
Thank you. That's good to hear.
Yeah, she was smiling. She was happy. You know, we had like a brief conversation. She sort of gave me a little handshake, but really compared to a few years ago when she didn't want anyone in her room, she was fantastic yesterday.
You know, Huntington's disease is a disease of constant change.
It is.
You know, I try to share with her that one of the guys who was on that ski trip many years ago with her is now
a resident there.
Yeah. You know?
Oh, I will send you his last name too. You wanted to, and for anyone that's listening too, I can send it to everybody or share it later. There's a person that is at Ferncliff who is from Long Island. And as Alan was saying, we went on a ski trip a few years ago and he was one of the members. It was a ski trip for folks with HD. It's a unique and amazing experience, but he used to do stand-up when he was earlier in his disease, and his stand-up revolved around having HD. It was pretty funny, and there's some YouTube clips of him, and so I couldn't remember his last name, but I got it, so I'll send it to you so you can look it up.
Or send me the link to the
YouTube.
YouTube.
Yeah, absolutely.
That's clearly allowed.
But the other thing is, I don't know if I misheard her or not, but we were putting Charissa's shoes on, and Alicia goes, "Oh, are those the new shoes your dad bought you?" And either she said, "Yeah, I like them," or "Yeah, I don't like them." But it made me laugh either way, because it was probably both true. But anyway, the new shoes you got her are nice.
So you put socks on her?
She put her shoes on without her socks.
Did you happen to notice that on Tuesday she had a rather large blister on her left foot?
So Alicia put her socks on, I didn't, but like very briefly when I looked over without inspecting anything, I did not see any blister.
Okay.
Her feet looked good, Alan.
Oh, hi, Alicia.
Hello. Yeah, she was fine. She came out with her shoes on, but asked for socks on. So
The blister's gone?
Blister's
yeah,
gone,
I didn't see any where you had mentioned she had it.
Good.
Hi, everyone. I'm back. So Francesca and I we've been troubleshooting in the background. One of our presenters is having some technical difficulties on her Mac, so what we're going to do is Francesca's going to work on that, and we're going to switch the agenda around just that, you know, we don't have to waste any time and we can keep things going. So Alicia is actually going to go in the place of Victoria's spot right now. So from 10:15 to 11, Alicia is going to do her presentation and some Q&A. Then we're going to transition into Julie for 10 minutes. Then we're going to transition into Victoria, and then we'll have our break. So I hope everyone's okay with that. But just want to keep the flow going and make sure we stick to time. So without further ado, I will pass it off to the lovely Alicia O'Keefe.
Okay, I am not the most tech savvy, Carissa, so you're gonna have to help me get
No
this
worries.
also.
If you want to share your screen, just take your mouse, hover it down over the bottom next to where it says participants, chat, and then it'll say share screen.
Yeah, okay.
Okay, so click that. It's going to bring a window up with everything you have open on your computer, and you're going to want to choose the one that has your presentation.
Okay, so I have that up. Can you see that? Hello?
No.
Once you select share screen and those windows come up like Carissa said, you might have to click OK on the bottom right for it to start sharing.
Okay, hang on a sec. Share. Okay, hang on.
Yeah, we're getting there.
I know, but now I lost my presentation. Hang on. Sorry. Okay, is that up?
Beautiful. Yep. And if you want to go down to the bottom right and then click that little pedestal, I always call it the politician stand, but that's
slideshow.
There you go.
Okay.
Perfect. All right. Thanks.
All right, we're ready to roll. So good morning, everybody. How is everyone? I'm sorry I couldn't get in a little bit earlier. So Dr. Hansball, I missed your presentation, but I heard it's recorded, so we'll go back to that. So I was going to talk today a little bit about our facility a little bit, and then long-term care, and what are some ways to prepare people for long-term care if you feel that that's an option that you wanted to look into for your family. So for those of you who I have not met, my name is Alicia O'Keefe, and I'm the program manager at Arch Care at Ferncliff. We have a Center for Neurodegenerative Care, which opened in 2015, thanks to a grant by New York State. New York is really leading the way in HD long-term care. New York State now has 3 units specifically dedicated to caring for those with HD. So Arch Care has 2 of those units, the Terrence Cardinal Cook Center in New York City. Ourselves, we have 39 beds, and Citron also was part of the grant when we opened. And we get calls from all over the country because many states have no care for people with neurodegenerative disorders. So we do provide care for people with HD and ALS. As it stands, all of our beds are HD residents. We don't have any ALS at this time. So when we opened up our unit, we did get some extensive staff training because working with people with HD obviously has its unique nuances. And we were very fortunate to have Dr. Tony Lekich and the expertise of TCC for 30 years helping us with the program development. And he's still involved with our unit. So we had our grand opening in 2017. We have had our full census. Whoops. Sorry, going early. I didn't get a chance to put Reese upstairs. So you might have a little barking in the background. I know that's a Zoom no-no. So we're a 39-bed unit. We currently have 39 residents. We also are able to accept people who are in need of placement to what we kind of call our overflow unit, which is 4B. And because we have a waiting list and people are always in need of beds, we went back to the state, and I'm really proud to say that we were given the opportunity to expand our unit. So we'll be renovating starting December of this year. We're going to be renovating 5A, which is the unit next door, and we're going to open up the entire 5th floor. as our Center for Neurodegenerative Care. It will be 66 beds, all private rooms. So we're really excited about that. Again, with New York State, they've really been in the forefront of providing this care. So these are just a couple of pictures of our unit for any of you who have not been there. This is just a little sitting room. We took out some of our rooms in order to make a little bit more community space. That's our sitting room and fireplace where folks like to relax. This is the back end of the hallway. Folks in the back end of that hallway sometimes like to sit out there, and there's a big window to the right. They can look out at the trees and the birds. This is our activity room, looks right out over the Hudson River. It's beautiful. We do all of our therapeutic, our art therapy in there, our music therapy, all our therapeutic recreation. My support group for the residents, we do that in that nice big room. And again, we're going to renovate the other side, and it's going to be very similar to this renovation. This is our community, our movie room downstairs. In this picture, it's set up for a wedding because one of our residents' daughters was getting married about 3 years ago, and mom was not in a condition that she could make it to the wedding due to distance. So she got married up at Ferncliff, which was pretty amazing. And that was definitely person-centered care in that case. So when I talk with folks who call regarding our unit, one of the biggest questions that they have is when really is the right time for long-term care? And it's the most asked question, and it's also the one that's hardest to answer, because I feel there's really no way to predict when long-term care is needed, because as we know, HD varies from person to person. And as Alan said, even earlier, the journey changes all the time. And support systems are very different. So one person could potentially stay at home through the entire progression of their disease because of their support system, their behaviors, allows them to do that. There are other circumstances where they need long-term care. And I think the most important thing to keep in mind is that someone's safety and well-being has to be the top priority. So, as we know, falls, choking, those are things that are very scary to people who are providing care to an HD person at home. And I think safety needs to just be the top priority in making that decision. All of the HD folks have different symptoms that needs to be taken into consideration. What is your support system at home? Are there people who are able to assist so that the person is not home alone if there is a fear of falling or choking? An HD person's acceptance of care. We see that often, that the caregiver is having a very difficult time because the HD individual does not want to accept that care. And that becomes hard. Sometimes you just want to be the wife, you just want to be the husband, you just want to be the mom, you just want to be the dad. You don't always want to be the caregiver, and fighting with someone to get in and take a shower. And of course, the family dynamics. HD is a family disease, so the family dynamics play a big role in whether or not the person would have a better well-being being in a nursing environment. Can you provide the 24-hour supervision if it's needed? You always have to look at the safety concerns in your current environment. And then, of course, the safety of the caregiver. We talk a lot about the HD patient themselves, but you also have to look as a caregiver. You have to think of yourself sometimes too. And I know it's hard because caregivers are very selfless people, but it's really important that you take care of yourself. Sometimes there's young children at home. And if we're dealing with someone who has aggression or violence, it can be a scary situation for young children. Compliance with medication visits, with treatments. That's kind of a big one. We get a lot of referrals because people say, I just can't get them out to appointments. I haven't been able to get them to the doctor. They won't take their medications for me. They need help and they won't accept it. Once they come into a nursing facility, we have the doctors right there. They don't have to go out. They have the nursing look in on them. They have the medications brought right to them and encouraged to take the treatments. So what I think is if you feel that long-term care may be inevitable at some point for your loved one, sooner rather than later. It's really important to be proactive and not wait for a crisis, to know what the options are. Long-term care is not an option for everyone, but it may be an option that you don't have that you wouldn't have a choice about if a crisis occurs. And it's better to be prepared and know what the options are than to wait for a crisis. And I think being proactive reduces fears. So it's very important to discuss the possibility of long-term care with your loved one along the way. Even if it's so far down the road that it would even, be considered, it's important to talk about it sooner than later, and include them in those conversations. Help them be part of the decision-making. It definitely helps with adjustment. Adjustment is difficult. It can take, some people adjust in a months. Some people take years. Some people never adjust. It's not an easy decision to make, I know, but I think reducing fears and going to the facilities and seeing them, I think that helps. I think it helps a lot. Definitely every time you go to see your doctors, I would just get their opinion about long-term care. What are their thoughts? Just in seeing the progression of the disease. And I know the Albany doctors come down to see us. So they know the services that we provide. They know the residents that are living in our community. So they would be totally open and honest about whether or not they felt we could provide the necessary cares. So I think it's important to visit the facilities of interest before the need arises and start building a relationship with the facility. What I like to do, and I've done with many of our folks that are there, they'll call me, come in for a tour. They know they're not ready for placement at that time, but then I maintain that relationship with them over the months or years until it's time for placement. So again, they know that long-term care is going to be inevitable for them, but they're not ready yet, but they start building that relationship. And I think that's really, really helpful. The HD resident who's coming to live there still would have a difficult adjustment, but the family having that relationship ahead of time, I think is very helpful. It's important to talk to families who have gone through it before. Everyone who's on this call today, on this education day, has their foot in the HD world, which means they've gone through what everyone is going through, and they're absolutely willing to help in any way. Discuss it with your support group if you participate in a support group. I think your peers, people going through it, families have the best advice, and I think you should use every bit of help that you can get in making these decisions. And then I would recommend, just talk with an attorney regarding the Medicaid eligibility and the financial component, because I'll talk about it a little bit later, but we have two levels of screening when someone's going to be coming to long-term care. We have the financial screening, and then we have the clinical screening, but I'll go into that a little bit later. So within our facility, and I think with the facility, all of the HD facilities and skilled nursing homes, we work on what's called an interdisciplinary team approach. So we try the best we can to have individualized, person-centered care. We want to get to know who this person is when they come through the door. What did they do in their past? What are things that they like? What are things that they don't like? As we know, there are a lot of OCD type tendencies with people with HD. What are they? What can we do to avoid any kind of behavioral issue? And what can we do to make this person feel most comfortable, that we know who they are? And that's really, really important as they progress in the disease. If their speech becomes impaired, that we know who this person is. So we recommend when they come in to really personalize their rooms, put posters in their room with things that people like, what their life was, and it gives us and the aides the opportunity to talk to them about things that we know they are interested in. So our interdisciplinary team is our medical team, our nurses, social workers, therapeutic recreation, our dietary staff, speech, physical and occupational therapies, and our psychiatric and psychology services. And we meet quarterly. We go over people's plan of care on a quarterly basis. Families are invited to attend those meetings. I know it was very difficult over this past year and a half with COVID that the families were unable to come into the building, but we still try to do conference calls when possible. So we create that plan of care, and our main goal is to maximize their physical function, their psychosocial well-being, and their emotional stability. So there's 3 types of care that we can provide within our facility. We provide short-term rehab if that's for like a brief stay of rehab following a hospitalization or an accident or an incident. They may just need maybe a 2-week or a 3-week stay to if they had a broken hip or something that would need a short stay. Anyone who would come to our facility would go to our short-term rehab, but one of the advantages of coming to our facility with even for short-term rehab is that our entire rehab department is so well versed in HD at this point that they would get the therapist to work on the HD unit for their rehab stay, and they would additionally get the dietitian and the social worker as part of their interdisciplinary team while they're there. And we have had some folks who have come for short-term rehab, have gone back home, and then as time went on, they came back for long-term care. It kind of gave them an opportunity kind of to try it out and see if they were happy with our facility. So long-term care is just when someone comes to live at our facility. We provide medical and non-medical interventions to enhance the well-being of the resident's life for the duration of their chronic illness. Right now, our HD unit is 39 beds. We are full. We have a couple of folks on 4B, which we said was our overflow unit. And again, we're really excited for the next year and a half to come to renovate our 5A unit and open up our long-term care options to 66 beds and private rooms, which we're really excited about. Because you can imagine sometimes having 2 HD folks in a room can be a challenge, but we've been doing all right. And then we offer respite care. So respite care is just a brief stay at the request of the family, so they can get a break from caregiving. A respite stay is usually a week, maybe 2, and we do provide that opportunity in a bed that would be available. So right now our HD unit is full, so we wouldn't have respite beds on that unit, but we could admit them to the overflow unit or even to another unit. And again, if someone with HD comes in for respite care, they would get the HD interdisciplinary team covering them. So you would have to check. It's a little tricky from a financial standpoint for respite care. Private insurance does not always offer coverage for a respite stay, but you'd have to check with your private insurance. Some long-term cares do. Some Medicaid managed long-term care plans have a respite option. And I know we do get some HD hospice at home come for like a 5 to 7 day stay. So if the family wants to go on vacation or if they have a wedding that's out of town. So we have had that. Hospice does allow a 5 to 7 day respite stay with us. So what is the process for admission? Once you have done your research, I would recommend visiting all of the units, whether it's TCC, ourselves, or Citron, see where you feel comfortable. If the time came that you really needed to admit your loved one, we would have to go through a screening process. So the first part is a clinical screening. What we want to see is what are the needs of your loved one and can we provide for those needs? And we would need paperwork. It's called a PRI and a screen. We'd need some medical notes. If they live in the home environment, we would probably go to your center of excellence and ask them for any of that paperwork. If they're coming from a hospital stay, we would get all the paperwork from the current hospital stay. And then the outreach coordinator, which is me, would set up an in-person visit if possible. Again, COVID made it very difficult because we're not allowed in the hospitals. I would typically go to the hospital and screen them in the hospital, or I would go to your home. I am allowed to screen people in the home at this time, but that's up to the person in the home if they feel comfortable with that. And I've also started doing, a lot more, obviously, through the Zoom screening. So we would do a FaceTime screening and just try to get to know the person. Again, takes away some of the fears. If the person with HD meets someone in the facility, gets to ask some of the questions, maybe sees, I would walk around with the iPad sometimes and show them the unit, just at least through FaceTime. I think that's important. So then our clinical team makes that final decision. Can we provide for them? Yes, we can. Then we go on to the financial screen. The only thing we really have to be careful of in our overflow, like to admit someone with HD in our overflow unit, is any type of behaviors that would affect other residents, because the 4B overflow unit has a mixed, it's a mixed skilled nursing unit. So we wouldn't want someone with behaviors or anyone who had some type of aggression or violent type behaviors. We would not be able to admit them onto that unit. So that's pretty much when we're screening them, we're looking for any type of behaviors that would be difficult for us to manage. And then we would go into the financial screening. So if the clinical team says, yes, this looks great, let's see, from the financial standpoint, what the situation is. So our admissions office and our financial screener will require some of the financial and insurance information and assure that they're authorized for long-term care. So if someone was coming in for a short-term stay, Medicare would pay for that. So if someone has Medicare in place, they're coming for a short-term stay, they would pay for that following a hospitalization. And Medicare typically offers 100 days, 20 is at full pay, 80 days, there'd be a 20% copay. And then if someone has Medicaid, in addition to Medicare, Medicaid will usually pay the 20% copay. For long-term care, a long-term stay, most of our folks are on Medicaid. So again, in anticipation of admission, I would talk to a financial advisor or an attorney about Medicaid and the financial situation that the person with HD is in, and whether or not they would be appropriate for Medicaid. Or they don't have to have the Medicaid in place when they come, but we have to have a good enough understanding that it will be, that it would go through and that the application is in and it's just pending. And there are some folks have long-term care insurance. We have had residents who long-term care insurance will provide partial payment of the bill. So you can check with your long-term care insurance and see if they have any kind of benefit for long-term care. Another way to prepare, and this is, almost irregardless of whether or not you're going to be looking into long-term care for your loved one, but just again, in preparation, advanced directives and how important advanced directives are for someone with HD. Really with any chronic illness, we should all have advanced directives in place. So there's a form that's called a MOST form. The MOST stands for medical orders for life-sustaining treatment. And when you go into a nursing facility, you're usually asked the questions on the MOST form as to whether or not you would want these treatment guidelines. So what they are DNR, CPR, would your loved one want to be resuscitated in the case of a cardiac arrest? And then there are treatment guidelines with intubation, hospitalization, artificially administered fluids, which is an IV or feeding tube, nutrition, and the use of antibiotics. So we do these MOST forms, and then they're updated monthly. In our facility, they're updated monthly. I think they have to be updated quarterly by law, but we do them monthly. And then if there's any change in condition and families or the loved one wants to change their MOST, they're certainly able to change their MOST. And they can be completed with a doctor at any time. You don't have to be in a skilled nursing facility to have a MOST. I would recommend people have these conversations, whether with HD or not HD. They're important conversations to have. They're difficult conversations to have in a moment of crisis. You want to have these decisions made. A lot of people know exactly, I don't want this, I never want a feeding tube. They're crystal clear. We want to know those things because if a crisis comes up, you don't want to be making those decisions in a crisis. So you can do that with your doctor at the doctor's office. There's also healthcare proxies, power of attorney, and living will. So a healthcare proxy is someone who you would appoint to make healthcare decisions in the event that you're unable to express your wishes. So while someone is able to make the decision, they want to be able to say, who's going to make decisions for me when I'm unable to do it. And then you want to have those conversations right away about the advance directives once you appoint someone. So a healthcare proxy does not come into effect until the person is deemed to lack the capacity to make those decisions. And that needs to be made by a medical provider or psychiatrist. And once the healthcare proxy is in place, then we would work with the healthcare proxy making decisions. And it could be temporary. I mean, you could need a healthcare proxy while you're in the hospital because you're unable to make decisions, and then you get better and you can make your decisions again. So it's not, cemented in stone. Your living will is a document that will state the guidelines for your medical treatment. You can write up a living will, put all of your treatment options in your living will, and we can do the most based on living will. It's just prior decision making. And then your power of attorney is the person that you would appoint to assist you with your financial decisions. Really, really important, especially if you're thinking about long-term care, to have a healthcare proxy and a power of attorney. You may not need it at the moment that you enter the nursing home, but to have it in place is really important, especially for the Medicaid application process, because you don't have to lack capacity for the power of attorney to work on your behalf. They can work on your behalf at any time once you appoint them. And that's really important, the power of attorney for the Medicaid process, because sometimes it's really difficult to get all of the paperwork that's necessary from the banks without having a power of attorney. Oh, that's it. It's an abrupt end. So I know I threw a lot of information out there. Does anyone have any questions for me? Hello.
Hi, Alicia. Can you send an email with your presentation?
Sure, I can send it. How are you, Barbara?
Good. How are you?
I'm doing good.
That was very good.
I'm doing good. Yes, I will absolutely. I can send that to you. I'll send it in like PowerPoint, in this format.
Okay, thank you.
Yeah, no problem.
Will you send that to everyone or just those who ask?
Well, Carissa, maybe I had sent it to Carissa, so maybe she can send it out to everyone who attended.
Okay, thank you.
Yeah, I'm happy. Or if she gives me everyone's emails, I can send it out. But if she has everyone's emails, maybe she could just send it out to everyone who participated.
Yes, I can. I'm happy to do that.
Okay, thank you.
You're welcome. All right. So does anyone have any questions at all about planning, or what does respite care look like if somebody? Oh, I see Patricia. Okay, great. Because we have 15 minutes, so feel free to ask anything. Okay, Patricia, I'm gonna. Francesca has to unmute you.
Okay, am I unmuted?
Mm-hmm.
Yes, you are.
Thank you very much. Yeah, I have a question. My husband is the one with Huntington's disease. If he should end up at Ferncliff, it's a drive for me. And I wondered if if you have places available where I could come and stay somewhere for 2 or 3 days. So because I'm getting up in age and I don't want to have to drive back and forth a lot.
Right, it's difficult. So we don't have places that are, that the Arch Care provides, but there are there are hotels right in town that some people who have come from far away stay there, or over in the Kingston area, which is right, it's right over the bridge. So there are some hotels right over the bridge
Okay, thank you. That's
that
good.
our folks stay in. Yeah, and we could, we would provide a list to any of our families that would want that, or, of places to stay that are nearby.
Oh,
Some
great.
people do the Airbnb route too. I know Rhinebeck and Red Hook have a lot of like small Airbnb type homes. So if people are traveling and come in, they'll rent the Airbnb for, a weekend. That way they have a kitchen and.
Is there a concern with COVID though for that?
From our standpoint, we haven't limited people going out on therapeutic home leaves right now. They're allowed to go out on therapeutic home leaves, so. And all of our folks are vaccinated.
I was just wondering in terms of staying at, well,
Right, like staying at the home then that might not be cleaned the way a
yeah,
hotel room would be cleaned. Yeah, that's a
right.
good point.
Yeah. Okay, thank you.
We do have, just to note too, I think like 98% of our residents are vaccinated, and that is one of the requirements for admission at this point, that anyone coming in would have to be fully vaccinated.
Good, that's great. We
So
are.
2 weeks, and then all of our staff as of October 1st have been fully vaccinated, so.
Okay, so if we were to come and visit and decide that, yes, this would be a place he'd like to go, do you have to get on a waiting list, and how soon should you do that?
Yes, I would do it sooner rather than later. That way your name will just kind of get on the radar. And the waiting list, yeah, I mean, I have a list of people who are interested, but they're not ready like at this time.
Yeah.
So if a bed became available and we knew that you were ready to take that bed, then I would call you knowing that you're ready, to place him at that time.
Okay, and if you're not ready, then you just stay on the list.
Exactly.
Okay,
Yeah.
thank you very much.
Yeah, so I have some folks who are like, maybe a year out, maybe when you have the new unit done. And until that time, I just try to, every couple of months, I'll just call and see how they're doing. And again, it just allows us to build that relationship. So I'll send you my contact information. It's on here, but then maybe we could set something up where you guys could come down and I'll give you a tour.
Great, I really like that.
Okay, wonderful.
Thank you.
You're welcome.
Alicia.
Yes.
This is Kathy P.
Hi, Kathy.
Hi. It has to be really terrific to have the neurologist come to your place. I mean, that's relatively all new that can happen, isn't it?
Yeah, that's real. We're very, very fortunate that we were able to get that connection with the Albany team to come down on a monthly basis. It's wonderful.
Yeah.
Our medical director, Dr. Kufner, he's a neurologist, and he comes in 3 times a week too. So we really do have some great oversight from a neurology standpoint. Mm-hmm. And they really, our families really love the fact that the Albany team comes down.
Yeah, I would think that would really, to me, that's a really an important component, to be honest with you. Yeah.
Yeah, it is. We're very fortunate. And our medical team loves for them to come down, and our nursing teams too, because it's a great education opportunity for them also. Mm-hmm. Because as we're discussing residents, they're learning, the nurses are learning and talking with them about different thoughts and ideas.
And gets a little free advice maybe for some others.
Yeah,
Right?
totally.
Yeah.
Totally.
Yeah, I think that's great. So.
Alicia?
Yes.
Pat Schuler here. I know each case is unique, but in general, how long would the process take from application to admission?
It does vary because it depends on where they're coming from, whether it's a hospital or coming from home. If someone was coming from home, I would say like within a month's time, you could have all the paperwork in order and a bed available to come. From the hospital, it has to happen much more quickly because hospitals say they're being discharged on Tuesday, they need to come. And they're able to get all of that paperwork done and sent over to us right away. So I had mentioned like a PRI and a screen that has to be done by a PRI certified nurse. And in the hospital, they have that, so they can get it done just like that. At home, you have to find someone. We have someone who we could send out to you if you can't find someone, but sometimes that, could take a week or so to have that connection and get all that paperwork done and sent to us. And then, of course, the vaccination status. If they're fully vaccinated, good to go. If we have to wait for the vaccination, 2 weeks past the second shot, then, that would put us out a month.
Okay, thank you.
You're welcome.
All right. Are there any more questions at this time? I'm thinking no. All right, well.
Thinking no.
My screen isn't shared right now, just because I had to put my laptop back on my charging deck, so I didn't leave y'all. I'll be back shortly. But Alicia, I just wanted to thank you for that presentation. I know how much your heart and soul goes into that unit, and if anyone was even thinking about placement right now or down the road, I could completely vouch that it would be like placing someone in a home, like a home full of love. And it's because of your spirit and your energy. So thank you, Alicia.
Thank you, Chris. I appreciate it. Appreciate that.
Okay. I want to just kind of transition into very quickly before we move on with Victoria's presentation at 11. I wanted to introduce Carla Mcdaniels. And, oh, there she is, her sunshine face just came on. So she is our Albany Chapter social worker. And, oh my goodness, Carla is my go-to. This woman is an encyclopedia of knowledge, and I look up to her all the time. If I have a question, she just digs right in and helps us get to an answer. And so we're so blessed to have her with Hdsa and working with our families that are, really going through some very difficult situations and processes. So I wanted to just take this time to put the face to the name. She runs our social work caregiver and HD support groups. And I'm going to stop now and just let Carla speak about herself. But I could go on and on about Carla and the work that she does for Hdsa. So without further ado, Carla.
Hi, good morning, everybody. Good morning. This is my first time being here at the Educational Day, so I am thrilled to be here and be a part of the Albany Chapter Hdsa. It has been such a pleasure to be able to come and give support and hold hands is what I say in regards to this community. I do 2 groups. One is the first Monday of the month. It's at 6:30 to 7:30. We've been having some guest speakers come in and talk about some really important topics as it relates to HD and readiness and emotional support. And then I do the caregiver group on the 3rd Saturday, in which we've been diving into some really important topics as to how it relates to a caregiver and to give you support. My goal this coming year is to get a cumulative list of possible supports to match with services. That's something Carissa and I are working on, and I am so happy to be able to be of service, to be of support. Thank you for the opportunity.
You've been very gracious. Thank you.
Thank you so much, Carla. I really appreciate that. Before we move on, Carla, can you just remind everyone in the chat the frequency of your support groups and the 2 types that you run, just so that anyone that would like to join has that information?
Okay. So I have 2 groups per month. The first Monday of the first Monday of, it says from 6:30, first Monday of the month is 6:30 to 7:30. And that's for the general. So anyone can come for that. And then we have the specific caregiver support, which is the third Saturday of the month at noon. And that's specific for caregivers. And please feel free to reach out to me for any questions, or if you need any assistance that I'm able to give support on. I'm always willing to take an email, take a call, and take some time. So thank you.
All right, thank you again. All right, well, I see that we have Victoria here, and I'm so glad you're up and running. So hopefully everything goes swimmingly well for you technology-wise now. So I'll let you just go ahead and kick it off, Victoria. Oh, you're muted. So
Okay,
let me just make sure.
now?
There we go.
All
There
right.
we go.
Francesca, so the problem was I was on a remote access from my facility, and it won't allow any of those things. So we've somewhat shared. Can you see my screen? Okay.
We can't see your screen yet. Did you click on the share screen button on the bottom?
Hold on. I'm just going to, there we go. I'm going to put this up. Yes. Are you seeing it?
Not yet.
Okay. So I speak too soon?
Once you selected share screen and that window came up, did you select one of the screens and then click OK?
I just did desktop.
Okay.
And share. All right. Saying open system. I've got you up. That's interesting.
Let's see.
Can you put mine up then? If
Yeah, I can put it up.
Yeah, let's just do that. It's been one of those mornings. I'll let you help me.
Okay.
Thank you.
Yeah, give me 1 second. I'll pull it up right now.
Put the slideshow up.
Okay, and just let me know when you want me to advance the slides for you.
Oh, okay. Oh, because I won't be able to? Is that what you're saying? Correct. Okay. So I'll just introduce myself. My name is Victoria Pringle. I am a speech language pathologist, and I work at a neurobehavioral unit and in Care One. It's called Care One in Massachusetts. And the other, she would have been a co-presenter, is Lauren Shirall. She's our rehab director, and she is an OT by trade. She has a vast, much more experience in terms of HD than I do, and we were asked at the last minute to kind of put this presentation together. So it's really geared, okay, yep, you're going ahead. It's just really our just small bios of where we hail from and our experience. And you can change the slide if you want. Thank you. So here's just a inspirational quote. We thought you'd like to see it, and I'm not seeing my whole screen here, but I'll let you just read it. And I'll just continue on, just given the amount of things we want to talk about today. Mainly the presentation is about cognition, communication, weight and nutrition, and really, swallowing that actually affects both of those. So can you advance the slide? Thank you. I don't think I need to really go into too much about HD as it was covered in the first presentation. I didn't know when we were going in, but usually, the cognitive signs, the mild, really slight signs occur much more frequently than any of the motor symptoms do. So it's a really huge focus to look at and to try and help individuals with HD kind of find out strategies, early strategies that they can continue to use throughout the process. And can you just change the slide? I'm not going to go through our it was an MRI, but I believe the neurologist did this justice. So I'm going to move to the next slide. Basically, cognition, we're talking about thinking skills in simple terms, and we can break it down into processing speed. Communication is huge, both understanding and expressing, being able to communicate with your loved ones, being able to communicate in the community in any type of setting is huge, especially as a speech language pathologist. Initiation of any task, such as eating, planning one's day, following a regular schedule. Attention, we can all be distracted, especially when we are bombarded by loud music, sounds, background noise, also our environment in terms of if there are a lot of windows, you know, some people are very sensitive to noise. That will affect our ability to process and deal with the incoming or actually express ourselves or people with HD. So the last 2 points would be planning and executive functions and memory. Can you just change the slide? Thank you. So processing speed is basically, you know, can we, when a good example is if you feel thirsty, do you always know you're able to be to say I'm hungry? We don't always know that until it's time. And it's even exacerbated with individuals with HD, that they're very hungry, but not able to see or say or indicate. And sometimes we see behaviors, especially in the facility that we work in, that if they haven't had enough calories or food throughout the day, individuals need more time to process information. And I would say, you know, whenever they're best, depending on the patient's or the individual with HD's schedule, you would know your loved ones best if they're at home and know how to help them optimize when they are, you know, you're either a morning person, afternoon person. For me, I'm better in the morning, and individuals tend to follow their own rhythmic patterns and be better at a different point of the day. Some like to nap, and then after that, they're refreshed and ready to go. So just be conscious of that. Slow and effortful. Make sure when you speak that we are repeating the information that we'd like them to see. And I'm repeating and slowing down my speech to highlight or exacerbate the need to use not so fast rate of speech and to repeat often just to aid in helping people understand. Communication. Communication can vary in many forms. Patients may have problems initiating and asking questions. So waiting is very, very challenging for many people. The silence is almost crippling when we have to ask people to wait to let people to have the time to respond. So often introducing a topic, do you want to talk about something to eat, or do you want to talk about something you want to listen to, is providing the patient or the person with HD choices versus just trying to wait till they formulate a question or a topic that they want to talk about. So yes, no questions, which are closed questions, are great to use, especially if you know or can guess what a person would like. You know, if you have the item in front of you, you can use objects. If you have pictures, if you're looking at going grocery shopping or things they want to eat, you can, do you want this versus that? Choices are great to hone in or simplify asking those kind of questions and getting answers. Thank you. And individual, when we talk about initiation is challenging in terms of starting different activities, such as setting up food, trying to get out of bed, get dressed. Often they may need some help to start that activity. So in our facility, you know, we work on providing cues, verbal are certainly used, visual cues, also using hand over hand for feeding, helping somebody pick up something. And once they have either a weighted utensil, they can bring it actually they can facilitate that movement a lot faster by initiating or assisting that initiation. And attention is really key. Try to eliminate any distractions, noise, attention to what you're asking somebody to do. Introduce the topic. Okay, especially if we're doing a cognitive task during therapy, this is what we're going to be doing right now, trying to repeat and express as much as possible and reduce any noise that is going on. People knocking at the door are a huge distraction in our facility. At home, there may be music, there may be TVs going. Sometimes those things may not be challenging. We might not perceive them as annoying, but if it's almost like sensory overload, a person with HD may be aggravated by those bombardment, if you wish, of sensory information. Change the slide. Thank you. So planning, following a schedule. Everybody, I don't know who right now is, if we have electronic schedules, paper schedules, if people used to use agendas. Also, whiteboards are great. Use of visual pictogram schedules. All these things help in terms of saying, this is what we're going to do now. And following that at whatever time, we're going to do something else. It's really nice to help with awareness of time and help in planning for the next thing that's happening. So in essence of giving patients anticipation of when something is happening, building it into their schedule. So if there was a novel event, like going out for an appointment, I would say really repetition and building into that daily schedule is a key component to, them not getting anxious about going, but also hopefully not perseverating on that item or going out for an appointment or a specific activity, perhaps a very preferred activity. They may tend to perseverate on when are we going, and continually ask those questions and keep asking. Also, the use of a calendar is a great thing, whether it be electronic on, our iPhones or iPads, or a paper calendar will also help in that, in terms of planning. So in terms of impulsivity, I think I just mentioned iPhones. We have some patients that are still using their iPhones, and they are very impulsive with phone calls and texting about, again, if they would like certain items purchased for them or certain things, an answer to a question or some information. They tend to just perseverate and just keep calling. And this has been somewhat of a problem in terms of calling loved ones or waking people up in the middle of the night just to ask some questions, which they can't wait for the answers, but it's very challenging for the caregivers at home. So that's just one example of that impulsivity of not being able to control that. I want this decision now. It's not a great decision to keep making these phone calls in the middle of the night. So memory, we talk about motor movement for memory in terms of forgetting. A great example is actually individuals putting food in their mouth and not knowing that they have food in their mouth. And sometimes that simple verbal cue to say, you've got food in your mouth, try and taste it, let's chew the food. It just cues them to, oh, okay, I should be chewing. I forgot that it was there. Or they were lacking awareness of it. When we talk about memory in terms of photos or long-term memory versus short-term memory, long-term memory is usually the memories from the past, and they're quite intact and able to tell us about the long-term memory. But as the HD progresses, that ability to learn something new is very challenging for patients or individuals with HD. So in the earlier stages, so in therapy at the moment, going back to electronic, we're using electronic calendars to input scheduling activities within our center, such as PT, OT, speech therapy, groups going on, and just outings, such as going out in the community now that COVID is allowing us to, those ability to actually use a calendar, although just to input the data when an individual can at this point in the progression of the disease is great, because we can kind of carry it over, because as their memory challenges increase, the ability to learn new skills is very challenging. So if you can start and be consistent and be able to adapt that into different ways to help them as the HD progresses, that they will be able to use a calendar. And also we're doing use of music, creating kind of a playlist, also an autobiography. We're actually taking photos and kind of collecting some of their history so that they can use it to help tell people about themselves, but also their likes, their dislikes, and things that they enjoy, and more really of an autobiography about them, and being able to go back and use it if they don't have the words or can't initiate a conversation to use it. So I'll let you just change the slide. I'm looking at the time. So I just found this great slide, and it happens that language is part of a major component. We have external factors and the outside external factors that will, affect all these aspects of cognition. And I think as caregivers, you will know the person with much more detailed, information. You know them much more intimately. And as therapists, we would love to know all those things that are potentially frustrating to them, that would alter their behavior, knowing what they like to talk about. Communication is huge in terms of being accepted into a community, having that social connection, and being able to enjoy life in terms of having a back and forth. If you can think of not ever talking to anybody, it might be challenging, but if people are asking you questions or bringing up topics you like to talk about, it makes it a much more enjoyable interaction. So we can move to the next slide. We talked about cognition, and cognition has a huge impact on communication. So when we break it down really briefly, when we talk about communication, it involves our thought process, muscle control for all the muscles that we need, going from telling our brain to move our mouth and all the muscles to produce sound, and our breath support. So breathing is huge in terms of facilitating or helping an individual with their expressive needs. So again, we kind of talked about all three of these issues in terms of facilitating their wants and needs. So if somebody, if you were to leave somebody or have somebody new come in the house, is the person able to communicate their wants and needs effectively? We all use text on our phones. We use pictograms. We use a whole different variety of communication tools to express our wants and needs. So I think at early stages, trying to put those in place are a great idea to help facilitate communication as HD progresses. Can you change the slide? Thank you. So just to talk a little bit about speech and language characteristics. There is huge variation, obviously, within the population and the community. There's challenges in terms of articulation. So when we talk about articulation, We're talking about movements of the lips, the teeth, the tongue, and ability to control your vocal cords and coordinate that with breath support. So articulation is perhaps affected by fatigue with some individuals, depending on what they do during the day. It's also affected by positioning. So if you have somebody that is preferring to stand up and they're not able to use their breath support, sometimes, providing alternatives to positioning while sitting down or while standing. We actually have, it's almost like a stand-up desk, and somebody has actually improved her breath support by actually bracing herself on the stand-up desk. So we're able to practice some breathing exercises, which in turn have supported a clearer articulation or ability to produce speech and produce longer sentences. So practice, and I hope you are getting, PT, OT, and speech services in the home. So I think practicing carrier phrases that, your person can use frequently. I want, do you have, do you like, if you were asking something. Some of those practicing will support the breath support, but also helps in terms of practicing with your lips and ensuring that planning is to the best of their ability and practicing with a range of motion. So for example, we see patients having problems with the ooh, ee, alternating with breath support. And so building in, do you want, exaggerating some of their articulation with breath support will help improve the quality of their speech in terms of layman's terms of understanding them. So in terms of that slushy, sometimes you hear consonants that are, it'll sound like an S, but it's more of a, it's kind of a slushy speech. So patients have been able to improve with therapy that is guided obviously by a speech therapist. Speaking too quickly. I hope I'm not speaking too fast. I'm trying to get through things right now, but speaking too quickly is something very common. And when you speak, or with individuals that speak quickly, sometimes they have even more misarticulations. So one of the patients I was working with, she was having trouble saying the word Huntington's. If you can think about that, it's a hard word to pronounce. And we broke it up into syllables, and she practiced, and she was able to, get her tongue up to that placement. If you think of the T sound, of getting your tongue up there, she was able to break it down and able to tell people why she was moving the way she was moving in the facility, or just able to, she was very proud that she could, say that she was going on a Huntington's walk and produce the word with the exact or closer pronunciation. So that's just by slowing her articulation down, or her speech. And volume. So volume is really challenging for individuals with HD. We have this variation of almost being, you'll see that the chorea is affecting every muscle that's involved. So your tongue, if your tongue is not moving, it's hard to coordinate with your vocal cords and bring that breath support up. And sometimes that chorea interferes with the breath support, with the muscles in the tongue, the lips, and the volume is almost what we say aphonic, that you don't even hear sound. So, or it fades out because they lack breath support. So in instance, they're trying to say a sentence and they can't finish the sentence because they have no breath to produce the sound. So when we take in air, we use that air to produce sound. So when they run out of breath, that loudness can be affected. In therapy at the facility I work at, we use music and music has been very salient for a few of the individuals who have loved to practice or some of the breathing techniques that we use. They take in as much, as they can, and they get to choose specific music that we kind of choose together to target some articulation in the same process. And they've been able to sing with songs that they like. So, and this is carried over to some individuals that are at a later stage and still like the music and able to produce, just one sound during the music, but they're still able to enjoy that aspect of it. So I think music is huge and very enjoyed by the patients that I've been working with, and a great tool to increase volume or, breath support for making sentences or phrases within or lyrics in a song. Difficulty starting a conversation. You may see people move away. Individuals in our facilities sometimes will ask for help from a therapist versus another resident because they are worried about not being understood or trying to initiate a conversation about a specific topic that they need information about. So facilitating that is maybe perhaps easier for individuals that are at home and their caregivers, because the individual wants to talk about a specific topic. Again, going back to overall communication and multimodalities and having subjects that that your loved one would like to talk about or interests. So complex discourse and socialization. So things that we take for granted, and topic maintenance. We can have conversations with people, perhaps switch topics, and individuals within the conversation are able to cognitively move from one topic to another. This is much more challenging for individuals with HD. We need to be staying on topic, possibly introduce the topic and say, hey, this is what we're talking about, and make it simpler so that they're able to engage as much as possible and engage socially as much as possible using, the social interaction skills that they have at their communication level. So we talked about communication and how do we know in terms of somebody's frustrated? Certainly we see behaviors with individuals with HD, but before that you may, have some language. We all can use colorful language or some inability to state how we feel, again, using a variety of ways. We, the good technology that we have here about emojis, sometimes a pictogram or a picture of, I'm really frustrated. Do we always know we're frustrated? We can be frustrated and be short with somebody. It's the same thing, facilitating individuals to be able to help them express their emotions if you know them very well. Things that would be triggers. Say this is frustrating to this person. It's great when you have home visits from like a team from Albany coming in and being able to explain your loved one or the person with HD's needs, and that would definitely help in terms of aiding with their communication and their communication style. You turn the stage or the page, sorry, or the slide. She's still there. Thank you. So really basic communication strategies. I kind of alluded to this, trying to, if they're having a hard time understanding or expressing themselves, we often see behaviors. So again, hoping to build in the most adequate faceted communication system you can. Any which way to get their point across is the easiest way to help as somebody progresses through the disease, having multimodal ways of communication to avoid those behaviors. Can you change the slide? Thanks. So some communication strategies, looking at a person instead of looking at the TV and then trying to talk to somebody, common things, saying their name to get their attention, use of a hand, trying to get their attention that way if they're attending to something else, if you're out in the community, clarifying what you're trying to say or asking it in a different way if we're not getting, or also asking the question and possibly helping them out with potential answers that you might envision them saying. Definitely providing time. Time is in a waiting and a response from any individual with communication impairments is huge and a big strategy. Thank you. So we talked about distractions. Some people, I think, that you can think about wearing glasses inside. People are bothered by the light from the exterior. People are bothered by certain noise. We have some individuals that like to wear noise canceling headphones because some of the noise from the hallway, some of the noise from the nursing staff, noise from their roommates bother them. So really having quiet, something to dampen noise or be attentive to things that may not bother us, but would bother an individual. It's great to know. And again, we talked about attention. If you're doing two different things and trying to communicate, it's not the best strategy. And again, if we're trying to go over music in the car or TV and raising our voice, it still is conflicting information that a person has to process. So narrowing down the topic, again, we talked about the main idea here. This is what we're talking about. Are you hungry? Trying to figure out what their physical needs are. So do you need to do this? Do you want to go to the bathroom? Or are you looking or seeking another activity? I talked again about yes, no questions. Yes, no questions are really a great way to kind of deduce and ask, hey, is this what you want? And hopefully people are able to, have different ways of, we can all nod if we're far away. We can say, use pictograms. We can use yes, no for our voice. We can use a whole bunch of different ways of using our body to express ourselves. So speaking slowly, speaking loudly, and some patients have benefited from giving them strategies such as the first letter. So do you want, an example was like a muffin. All right, let's start from the letter M, and they were able to deduce and come up with a word, again, to help with those word finding activities or keywords regarding a specific topic. Cueing and refocusing can help too. If individuals start perseverating about a particular topic, but we're trying to get them to eat, let's do this first, and then, we can do the other activity. So first we'll eat, and then we'll listen to music. A patient that I'm working with loves to sing, and he's not so motivated to eat, but we help do the first, next, and he's able to initiate and do more of the self-feeding on his own right now. And then he knows we're going to sing. And from a speech language perspective, we know his quality of voice is great because he's able to sing with the music that he likes. And it's nice and dry. It's not a wet quality. So we know it's not going down the wrong way. So we can move on to, I think, so I talked about alternative and augmentative communication. An augmentative system is something that is unaided. We use our body language, we use our facial expressions, vocalizations, gestures, and those are all things that we don't need any tools to do. But then we go to aided systems. You can have pictograms that are very simple. You can have communication boards. You can also have some low-tech devices that are just that answer or ask a question, all the way moving to things that are a little bit more advanced. So depending on technology that individuals like, iPhones, smart tablets, these things are becoming increasingly interesting to use as alternative and augmentative systems. So and then moving on to much more advanced systems from companies that use systems like eye gaze devices that can be embedded into a computer. So even knowing to scan, again, going back to that relearning, knowing to scan from left to right, building certain things that can transfer over into a more advanced augmentative system is, or an alternative communication system is a nice way to set up communication, which can move through stages of HD. And again, oh, sorry, thank you. Yep, you can go back. So this is just an example of something that's kind of low tech. It's used with a computer program called Boardmaker, you know, and if patients can't use their voice and they're able to point to, can I have, and this one, you know, my toothbrush, can I have the newspaper, or indicating I don't want a specific thing when somebody is offering it to them. It's just a really easy, quick communication tool, and it's very low tech. Sorry. So going back to speaking and swallowing, breast support and the coordination between all the muscles involved in speaking and swallowing are problem areas for individuals with HD. So any way we can support or improve that. I said numerous times, use of music, hydrotherapy. There's apps if you're interested in using technology that there's about, I Googled it, I was going to try and link it to the presentation, but 13 apps that are free on iOS, Android, devices that you can download. They have biofeedback, so you can breathe in and breathe out and really practice some breathing support exercises that would help in terms of facilitating speech and hopefully with swallowing. Thank you. All right. So this was just a break of the presentation to say, breathing also helps us as therapists and other as a caregiver or being at home to relax, and being able to do that practice is sometimes challenging. It's not just breathe, but if we can remember that if we can practice this with a person with HD, it actually lowers our cortisol, takes the stress away from us as well. So I would, encourage anyone to just Google, breast support exercises, some meditation. If you're not into using apps, that would be a great thing to do at home. So you're okay. Thank you. So eating, dining is something we all do. Individuals with HD have trouble sometimes initiating. And again, that cognitive aspect can lead to frustration. And also people, within our facility, we have individuals that are able to still feed themselves, but do not want to be out in public. So during COVID, they were in different dining facilities or eating in the room, which was fine. But, now that individuals are able to go out in the community, we have some individuals that want to eat not with the group that they're going out with. And so, they can it leads to, they become uncomfortable. They may have behaviors. So to really know the person's preferences about eating is a great thing. They're also worried about spillage, fluids or food coming out of their mouth, and food on the floor. They don't want people to see them being messy or not able to get the food to their mouths. So the use of adapted equipment and giving them enough time and to the preference of where they want to eat is a huge factor. So I'm just going to ask you just to change the slide. I think the next one is, okay, I was talking about altered textures. I'm not sure in terms of when you're receiving speech therapy at home, if the speech therapy, some things are easier to swallow. So you'll find obviously meat chewing and that coordination going to be harder. So you really need the expertise of a speech language pathologist to come and help with hopefully avoiding aspiration. So any texture, whether it be pureed, like a apple puree texture, from something as simple as meat or ground food, can be aspirated. Any texture additional to water or thin liquids are sometimes the hardest to control. So just being aware of if there's excess coughing, to really try and call somebody and see if you can get somebody to come and consult with you, or even via Zoom to say, okay, do I need some help with the postures? One really good thing is a chin tuck to avoid getting in this position. If we're drinking something and we're hyperextending, that's actually opening our airway. So, and we probably all do this, if you can think about having a cold drink or trying to get the last little bit out of a can, that hyperextension would possibly lead to possible aspiration. So you just want to be conscious of those things and to help somebody be the safest possible at home. I would really recommend calling the speech language pathologist as soon as possible. So also, I think this was talked with the previous speaker, there are advanced directives, knowing what somebody would like in terms of feeding is huge. I have a patient on my caseload not interested in having any altered textures, does not at all want any of those things. So those have been discussed with the social worker and the team. So respecting that person's wishes is key as well. Just turn to the next slide. So I think we talked also, I'm just going to, we alluded to the choking hazard, and just in terms of you're helping feeding somebody, please stop if you start hearing coughing. It's pretty a huge sign. Please do not, I've seen, try to feed somebody that is in process of coughing. It's very challenging to wait and offer. Sometimes alternating solids and liquids are a great idea to avoid or to help clear if there was anything from a swallowing perspective that is in be stuck in the moleculi, but also a different, if you have residue on your tongue or residue between your cheeks, and to swish the water around or a thin liquid might help. So I'm just going to go to the next slide. We talked about barriers, hand over hand. Having the next slide will actually be, if you can just go into the, sorry, can you change the slide? I'm sorry. So adaptive equipment, some of those barriers are to help a person. I'm sure, I just brought a few things from our rehab department. We have some adapted weighted utensils. These are great because it also allows the patient to be able to grip, but we can help hand over hand to assist. And they are able to feed themselves independently as long as possible with these adapted equipment. So we have covered mugs. I just gave there's some examples listed. This is a blue mug we have at the facility. I also, just the Wonder Woman cup with just a straw that you could probably access anywhere is also Good. I'm sorry, my daughter is waving at me. Yes. I apologize. That was my daughter. Just some, adaptive equipment. We have a weighted plate. Lift guard plate and a lift guard that actually goes on. Definitely OT can help you in terms of some of these things. And you can see it's got little like suction cups, so it does not move. So those are great things to know about. And definitely straws are sometimes easier from a perspective of swallowing versus trying to have a lip seal and control the cup and the liquid inside the cup. So those are some of the quick overview of dining equipment or things that you can use. So again, we talked about reducing distractions, pacing. Sometimes it takes a long time for patients with, especially in our facility, we're encouraged patients to feed themselves as much as possible. And it can take up to an hour for them to independently feed themselves or with a little bit of assist. They take small bites using, again, we talked about alternating solids and liquids. It's the safest thing for them. And we talked about the coughing. Again, in an upright position, we have some patients that we have high back chairs from, and we actually position them against the wall so the chair is not moving while they're eating. So those, and it also helps when we talked about maintaining a neutral position for swallowing. They're not getting into hyperextension and possibly increasing their risk of aspiration. So those are, some little strategies that might help in terms of feeding. Also stability, leaning on the table and being able to stabilize your arms and your body might also help them. And again, you could consult with the OT and speech in terms of some of those strategies. So a calm environment, that may mean different things to different people. We talked about some of the adaptive things. Sometimes too many things on a tray is really hard. So, or on a table, perhaps setting it up, making it accessible that they can reach one at a time. Altered diets as prescribed, if you need help with that, the speech pathologist would definitely be able to give you a hand. Frequent snacks, which will lead us into a bit of the weight and nutrition because of the calories that are burned or potentially burned. Every individual is different, but the Korea movements, they need at least up to 5,000 is a minimum. We have some patients that are hopefully consuming more. We're part of one of our cognitive tests with some people is that they actually know how much, the fluid in here is 12 ounces. And we have some nutritional shakes that we put in here that are high caloric, but are low volume. And they get close to, so this is about 12 ounces, they would get close to 1,000 calories in a smoothie or what we call a shake, depending on what they like. So we want to encourage them to have some of more calories and not feel like they're overwhelmed or being forced to eat. I had one patient I said, what would you like to have known before you came to the facility that you're in now? And she said, well, I was having to eat hamburgers for breakfast. And she goes, and trying to eat so much food, she goes, I would have liked to know about some of these recipes. I said, oh, that's great information. And so this is kind of where I think we shared. The next one has got a few slides on it. I don't know how I'm doing for time. I haven't even looked. I'm at 11:45. So we're just going to jump through to.
Victoria?
Yep.
Yep, you're good. You have about 10 minutes left. And if you want to carve in some time for QA there as well.
Yeah. So 10 minutes total or 10 minutes?
I would, 10 minutes. And then we'll give everyone just a little 5-minute recoup and then we'll jump back in.
I'm trying to go. I was like, It's a lot of things in 45, but we're good.
If you want, we can go to 12 without a Q&A.
I think Q&A is probably good because I'm almost at, it's more, it was just the question of going through some of the, food items.
Okay.
Yeah, we can just.
Yeah, that'd be great.
So the high caloric shakes are great. We talked about finger foods. So, on the go, peanut butter is one of our favorites for one of our patients, and cutting it up so it becomes almost like finger foods for the person is easier than taking big bites. In like going for a picnic, for instance, is what they did last week. Fluids. Well, we talked about fluids with the shakes, but also encouraging water. Anecdotally, I've witnessed, and my rehab director is, sweating or being constantly thirsty. So that's been reported by some of our patients. So making sure that they're drinking when asked or being offered enough fluids, because they tend to perspire more. So that's huge during therapy. We always have water as speech to the pathologist, which mine is here, to drink to hopefully for our vocal cords, but also to help with hydration for patients or individuals with HD. So here in this handout, hopefully that will be shared with everybody. We talk about building this high caloric, low volume smoothie. So by low volume, it means that it's as much, if you think about it, compressed calories and not feeling as if they're totally full, if you wish. So it just breaks it down into different liquids that you could use. And I'll share with you one that's a favorite that I developed that has gotten very, it's almost non-dairy, but it's low lactose. And it's been described as a peanut butter and chocolate, like Reese's Pieces kind of shake. And the patients, we kind of developed it together to help with a patient who was having trouble basically swallowing. The viscosity in terms of the saliva had changed. So we came up with a shake for him to swallow without dairy. So non-dairy shakes are great for patients that are having some difficulties with the viscosity of their saliva. It's almost as if they're having a cold or spitting, when you've got to clear your throat. So that's one thing you can specifically speak with their speech pathologist. If you go down a few slides, sorry. So these included are some smoothie recipes. So if you just like, oh, I'm just going to go to the end of them. Right there, the peanut butter. Oh, sorry. The peanut butter and chocolate one is the one I did with patients. And we did it as a cognitive exercise, measuring things out, but also in preference to what they like. So it does truly taste like chocolate Reese's Pieces. And you can see, so this is roughly about 12 ounces and they're getting 790 of calories, which is pretty huge if you think about it. And going back to the analogy with the hamburger, a regular hamburger, if you were to make it at home, is about, anywhere between 250 and 300 calories at home. And the last slide I'm going to show is the analogy of if you were going to McDonald's or dining out, this is not a picture of, and I don't want to be copyright infringing or anything with the McDonald's name, but McDonald's hamburger would have 520 in calories. And also, if you are going out and they want a shake at McDonald's is, get this, 530 in calories. So that's a lot of calories in terms of swallowing. Stop. Sorry, that was my daughter again. I apologize. Are there any questions? Or I know I just covered a lot of information very quickly.
I got a couple of things I wanted to briefly ask you about.
Sure.
Lemon juice to
Yes.
clear the throat or reset the palate after a choking experience. Carol Moskowitz from Columbia once recommended that to our group.
Yeah.
I've never had an opportunity to use it. Do you have any experience with that?
So we do know that lemon, that's, so when you think about all the different tastes, like spicy, sour, all those things, they basically almost like awaken your mouth. So we do use some of those things to see if patients, and also cold. So using a cold spoon sometimes will help the swallow. And I would definitely refer you to, consulting with the speech language pathologist, because there's different techniques to try with the individuals.
So you've used lemon juice.
Yeah, well, lemon, that sourness is almost, well, if you think about awakening your muscles, it's kind of.
So is it straight or is it diluted with water?
I think in terms of post-choking,
Yeah.
I would say coughing and clearing, I would not advise giving somebody in the process. If you hear them coughing or I would encourage them to keep doing that before giving them anything. Does that make sense?
Maybe.
Yeah, so it's one of those questions clinically, I would say, I would ask, sometimes we need to see eyes to see what's going on before saying, do this. And I would be ill-advised to say, this will help. But yeah, if someone is coughing or having, you can see them, I'm pulling down a scarf, they're having trouble, really, like, we wouldn't want to give them anything in their mouth. We would want to try.
You're right. I mean, after it stops.
Right.
Yeah.
Yeah. So.
So you mentioned singing.
Yes.
It's very difficult to get my daughter to practice any therapeutic exercise.
Okay.
The hints you have on that would certainly be appreciated. Do you think, as a general proposition, just singing along with her would be a therapeutic breathing exercise?
So if you think of singing, there are so many words, and sometimes, we've actually listened to heavy metal in our group because one of the patients really likes heavy metal. So, and we pick certain sounds that they have patients like, and from a speech pathologist perspective, I, in my head, have a target of working on specific sounds and how short the phrase is. So I think, yes, if she likes music, I think, if you have YouTube, you can sing with, and you can do different things to slow the music down or pick different songs that could be fun for her. I'm not sure what kind of music she likes, but yes, I think it would be a great tool if that would get her to buy in to wanting to participate.
Okay. Any tips on how you can get somebody to practice any of their OCTC speech, when they're not with the therapist, just kind of like,
Yeah, so I buy into it's got to be fun. It has to be fun. It really has to be enjoyable to the person. So does she have other interests that she likes? Does, one of the patients we have, it's a huge, all it talks about is candy, wants candy. So we did a whole therapy session about asking questions about what kind of candy different people like. And we made a list of candy, it has to be something that is enjoyable to that specific individual. So if she has a specific interest, that's where I would go, and try and.
Thank you. Yeah. That's helpful. Thank you.
You're welcome. Is she, whoops, sorry. I just said another, whoops.
Oh, hi, Victoria.
Hi, sorry.
Did you want to go for another couple minutes? Because we have 5, but we can go ahead and end it now and give everyone a quick break and hop into Alan.
Sure, no problem. Thank you.
Okay, great.
Can I just say something really quick?
Hi. Yeah, definitely.
Victoria, this is Carla. I just want to thank you so much. Your co-worker. I'm your New
I
York
said
Gina.
hello to you. Yes, yes. I realized that when you came up. It was a pleasure. Thank you. I'm sorry if it was really rushed and kind of what we say pen pal put together. I really tried to just pack it all in there. So I would love to know more about your groups though. Okay, fabulous.
Thank you. Bye-bye.
Bye.
All right, so Victoria, I just wanted to thank you so much. I thought that was really thorough and really helpful. And I can't stress enough, thank you, thank you, thank you. I know that, you know, we asked you a little last minute. So again, just, I really appreciate your time today. Great material.
Thank you very much. I hope it was okay. I was a little kind of, you know, trying to get
No,
it
I know you had a rough start, but everything was amazing. We always work it out, right? That's life.
That's it.
Okay, so I think what we'll do, if everyone doesn't mind, is we'll do a 10-minute break now, and then Alan will get you queued up and ready to go. And if you, yes, okay, 12:10 to 12:40 is Alan. So let's go ahead and do a 10-minute break.
Okay, great. I'll get a snack.
All right, welcome back, everyone. It looks like it's 12:10. Alan, are you ready?
I'm here.
Oh, fantastic. Wonderful. All right, well, I will go ahead and hand it off to Alan. Alan, again, thank you so much for taking the time to speak. Very excited to hear what you have to say. And I'll go ahead and mute myself and let you get going.
All right, great. All right, so can everybody see this? All right, we're going to start the art of advocacy with some demonstrative evidence. Our fishy frolic t-shirt. Okay, this is this year's t-shirt. And if you're not envious, you should be.
I love it, Alan. It's a great look.
So every year, for the last several
You
years.
wear that well, Alan.
Oh, thank you. We've done a walk-run fundraiser for Huntington's disease at Corning Preserve. It is a wonderful event. We all get together. We have a great time. This year we raised over $33,000, and that's one of the things that we do. So let me just tell you a little bit about myself, and I'm going to talk about two pieces of legislation: the federal, what used to be called the HD Parity Act, and the New York Personal Caregiver Law. And I'm going to discuss 3 books that I highly recommend people read. So my daughter Charisse will be 41 at the end of next month. And she has Huntington's disease. She was diagnosed 11 years ago. For the first 5 years post-diagnosis, she lived with me and my wife, Lenora. And she's now a resident at the Ferncliff nursing home. She's been there for over 5.5 years. I've been involved with HD for a very long time. It's actually been one part or another of my life since 1988. And I serve as the advocacy chair of our local chapter of Hdsa here in Albany. I work on legislation that may affect our Huntington's community. I do police training twice a year. I'm a retired attorney. Since Jenny mentioned police training, the core of that is the Hdsa Law Enforcement Toolkit, which has 2 parts, tips for police and tips for people with HD and their families. I urge everyone, if you have a loved one living in your community, download the Hdsa Law Enforcement Toolkit, set up an appointment with your police department, show it to them, talk to them, bring them a picture of your loved one, acquaint them with the disease, and educate them so that if your loved one is stopped by a police officer in your community because a neighbor thinks that there's a drunk walking through their backyard, they will have background and they will treat your loved one appropriately. It can be a major difference. So a long time ago, I wrote a letter to Senator Gillibrand asking her to support the HD Parity Act, which at that time only had a House bill. I spent almost a year together with the professional lobbyists from Hdsa to accomplish that task. My letter opened the door. Several months after my letter was sent, I got a call from a staff person in the senator's office, and the staff person's opening line was, "We got your letter." That bill, somewhat changed from its initial version, is still waiting congressional action. And I tell you this, not to brag or boast about myself, but to encourage every individual person to take action, okay? You never know what the ripples in the pond lead to from the stone that you threw in that pond. So today, the HD Parity Act is known as Huntington's Disease Disability Access Act of 2021. In the House, it is bill number HR 2050. The lead sponsor is Representative Bill Pascrell Jr. from New Jersey, and it has 65 co-sponsors. In the Senate, it is Senate 868, and our Senator Gillibrand, continues to be the lead sponsor, and it has 5 co-sponsors. So we got a long way to go in the Senate. If you have friends in other states, please encourage them to contact their state senator, urging them to be a co-sponsor on this bill. What is the bill? What is it about? Excuse me. Under current law, everyone eligible for Social Security disability insurance, known as SSDI, is also eligible for Medicare after a 24-month qualifying period. The first 24 months of disability benefit entitlement is the waiting period for Medicare coverage. So in other words, you got to get money, cash benefits for 24 months before you can get Medicare. During this qualifying period for Medicare, the beneficiary may be eligible for health insurance through a former employer. In other words, once Social Security determines you're unable to work and makes the applicant eligible for early Social Security retirement benefits after 24 months, the disabled worker can get Medicare. Or they may not be eligible for employment, post-employment health insurance from their employer. Or they may have to pay COBRA. And if you're unemployed, you may not be able to afford COBRA. So what this bill does is it eliminates the 24-month waiting period. Currently, there are 2 illnesses that do not have to wait 24 months to get Medicare: ALS and end-stage renal disease or kidney failure. The purpose of the waiting period is to save the federal government money. It's a cost savings provision. There's no health-related connection. These 2 diseases that are exempt because the affected person often does not live 2 years. So our HD bill is a bipartisan bill. Both chambers have co-sponsors from each party. In our area, Congressman Tonko and Congressman Delgado are co-sponsors. However, Representative Elise Stefanik is not. If you know anyone who lives in her district, please ask them to write her, asking her to be a co-sponsor. Similarly, ask your friends and relatives in other states and other places in New York to ask their representative to be co-sponsors. New York only has 3 co-sponsors. The third is Representative Meeks. This bill is important. Think about how the average person with HD is affected by the loss of medical insurance. The average person is 45 years old and has health insurance through employment. If the person with HD is the source of the insurance and it's through work, and the person is no longer able to work and they lose their job, they may lose their health insurance. Many people with HD can't afford COBRA for 2 years. And this is particularly important if the person is unmarried, because then there's no spouse to pick up the health insurance. An alternative is Medicaid. But many people who have onset around 45 years of age have a lot of work experience and they've accumulated some assets. So they may not be able to get Medicaid because they're not poor enough. So they're in a real bind. Too many assets for Medicaid and not enough to pay for private insurance. So that's what I wanted to say about the HD Access Act. The other law that I want to discuss is the New York Personal Caregiving Visitors Law at nursing homes and other facilities. In short, this law that was enacted this year permits a family member or other person designated by a resident as a personal caregiver to visit a resident and perform caregiving tasks for a resident in a nursing home during a public emergency when normal visitation is suspended. The COVID pandemic was very harmful to residents in nursing homes in many ways. One of the ways that people suffered was through the loss of visitation by family members. It is well documented that isolation injures people's well-being. For me, I was locked out of Ferncliff from October of 2020 until the end of March in 2021. Because under New York State Department of Health rules, when a staff person or a resident tested positive, the facility was closed to visitors for 14 days. And at Ferncliff and at most nursing homes throughout the state, this was a regular occurrence. It didn't matter that the person who tested positive had no symptoms, or it could have been a false positive, and vaccinations didn't change anything. Had this law been in effect, the lockout of people like me who feed, wash, clothe their loved ones would not have occurred. Caregivers like me supplement the very stressed out nursing home staff. We are adjuncts. We just don't go in there and drop off flowers or a book, as many people who are visiting a person in a hospital do under normal conditions. So what happened is that this law passed in April, and it was in effect for a very short period of time. It was signed into law on May 13th, 2021. And as soon as the governor declared that the public health emergency was over on June 23rd, the Department of Health declared that this law is no longer in effect. So just to show you like how dramatic this is, we have this law. It allows these personal caregivers to come into place during a public emergency. The public emergency no longer exists, but the nursing home is still obligated to have all the COVID rules in place. You have to have your temperature taken when you come in, you have to wear a mask, you have to maintain social distancing. And earlier this morning, during this education day, I got a robocall from Ferncliff telling me that a staff person was infected or diagnosed positive, not necessarily symptomatic, but diagnosed positive because they had regular testing, and visitation is generally closed for 7 days. If this personal caregiving law was in effect because we had a public emergency, it would be allowed in. Now, you can still get in if you have a compassionate care allowance, but not everybody has that. So a family member might have a compassionate care allowance, but a friend of the resident, who sees them, twice a year is going to be subject to these visitation limitations. So Senator May from the Utica area, who sponsored this law, has realized the error of the legislation, that this should be a permanent right of visitation that is not subject to waiver during an emergency, and she has taken action to try and fix it. She has introduced in the New York legislature, Senate 7346. In my research, I was unable to find a companion bill in the Assembly. And of course, you need a bill to pass in both chambers to become law, and you need the governor to sign it. And this Senate bill, as of now, has no co-sponsors. So we in the Huntington's community need to take action on this bill. We need to write Senator May, evidencing our support, and we need to write to the governor and our senators and assembly representatives urging their support of this bill. We need to tell them to pass this bill. We need to tell them that lockouts still occur. Also, there are lockouts under other circumstances besides the coronavirus. You can have a lockout on a facility-specific basis because of a normal flu infection or a neurovirus, which affects the stomach. We need to tell our lawmakers that our loved ones are depending on us for their well-being. So I want to tell you a short story that, in my view, emphasizes the role of individuals. I want to tell you about the origin of this personal caregiver visitor law. I was informed by Assemblyman John McDonald, who represents parts of Albany, but mostly Cohoes, that the need for this legislation came from a hearing that he was chairing in August of 2020. The Assembly Committee was expecting to hear from nursing home resident family members on deaths in the nursing home during the coronavirus. And they probably did hear about that, but the committee was surprised about how family members complained about not being able to visit and to help care for their loved ones. The Assembly members were surprised to learn that the health and well-being of residents was adversely affected by the lack of visitation. And so two competing bills were introduced, and the one that was submitted by May became the one that was enacted. In the Assembly, it was sponsored by Assemblyman Bronson from Rochester. And while there were Facebook groups and other organizations that formed around this and other nursing home death issues, it was the individuals who took the time to go to the assembly hearing and tell their individual story that made a difference. I was lucky to play a role. I spoke about the problem and the legislation on an NPR radio show broadcast out of Assemblyman Bronson's district. And I was able to get the ear of Assemblyman Thomas Abenati from Westchester, who took my concerns with the original bill to the Assembly Health Committee, and a few of the ideas that I had for improvements, not all of them, were amendments to the bill. Everyone on this Zoom has the power to be a change agent. Just do it, and don't assume that someone else will. When we don't speak up for our community, no one else does. So I want to sort of close this out on a more upbeat note by mentioning 3 books, all of which I have read. And since I'm living Huntington's disease, I usually don't read books about Huntington's disease. But I was wrong, and I found that these books were very helpful. So some of the stories include doctors telling caregivers that their loved ones could not possibly have HD because they did not have chorea. Stories of arrests, no competent medical advice available, family disruptions, the things that we collectively all experience. In terms of the nation and the lack of HD experience with doctors, we are so blessed in New York to have the Albany Movement Disorder Hdsa Center of Excellence, one in Rochester from Strong Memorial, and one in Columbia, in Manhattan. And I believe there are 54 scattered throughout the nation, but it is a real blessing for our community. And my thanks to all the folks at the Albany Medical Center for doing what they do. So the first book is entitled, Can You Help Me? And I first saw this book at an HDSA national convention. I bought mine on Kindle. I like to read books electronically. It was $10. The second book is called Life Interrupted, Living the Unimaginable, Huntington's Disease Patients and Caregivers Sharing Their Truth of Strength, Courage, and Perseverance. And it's by Katie Jackson and Vicki Owen. It has 12 chapters by individual caregivers and people with HD telling their stories, and a final chapter written by Jimmy Pollard. And I think everybody on this Zoom probably knows who Jimmy Pollard is. Another Kindle book for $10. The third book is entitled Living with Huntington's Disease, What I Learned as a Caregiver by Sharon Thomason. Another Kindle book for $5. And I will brag a little bit. Sharon included a chapter about me and my work on medical aid in dying. I had no idea that she included me in her book. I get no royalties from it. It was a total surprise. So if you do read the book and you see the chapter about Alan Pfeffer, don't think that I profited from it. There is no conflict of interest. And please, as you go through, as we all go through this journey, please remember that you are not alone. We, the Albany chapter of Hdsa, can use your help. So if you're interested in volunteering for the fishy frolic that we do in August, here's the shirt. You get a shirt, volunteer, get a shirt. Or perhaps being a member of our board or volunteering for any other of our fundraising events or soliciting donations, please call our president, Jenny Hart, and here's her phone number, 518-423-8171. And I'm going to close, hopefully, by showing you a short one-page summary of the bill numbers and the names of the books, which you can either do a screen print or I will send a PDF of it to Carissa and perhaps she can include it in her mailouts. All right, so now I just have to figure out how to share the screen. That's not my screen. Carissa, are you there?
There should be the green button at the bottom of the screen.
Yep, I got that. And now I have a thing that says, I guess is it my desktop that is, well, no.
Yeah, go ahead and do my desktop and then click share or okay.
All right, but below that, I think is the page I want to show. So I think this is the way I do it. Let's see. Yes, can you see that?
Yes, we can.
Okay, great. So I invite everybody to take a screenshot or perhaps it can get mailed around. Okay, I don't know if anybody has any questions, but I got 5 minutes.
Alan, I don't have any questions. This is Carissa. I wanted to thank you very much. And just let you know that when this is done, you can send this to me and I'll send it over to the, well, I'll share it with HDSA so that either Virginia or maybe Jen can help me getting it out to everyone that registered.
Great. And just as a closing thought, if anybody is going to talk to their local police department and they want to review it with me before they go down, want some tips, I am very, very glad to share my experience with you. And you can email me and, send me your phone number and we'll call. My email is the number 2 followed by my name, Alan Pfeffer, no spaces, @gmail.com. I did find when I went down and spoke to the Bethlehem police, they're very well received. They were very cordial. One of the 5 sergeants that I met with, or 4 sergeants that I met with, actually had an encounter with a Huntington's disease person. And so maybe that made a difference. I don't know, but they were very receptive to listening to me. And when my daughter was stopped by the police, that encounter worked out to everybody's satisfaction. All right, I'm done. Any questions?
I have a question. Do you have a list of all the politicians we should be writing?
Where do you live?
I'm in Saratoga.
Well, if you go to the Assembly and the Senate pages in New York State, there is a Find Your Representative bar, and you put in your address, and it'll tell you who represents you. I don't know if you're in Tonko's district or if you're in Stefanik's district, because I think they kind of split Saratoga.
Right.
So I can't answer that question for you.
Okay.
And then, yeah, and then if you do this, oh, I'm sorry. You have to go to the Congress page to find Stefanik or Tonko, and the New York State Legislature, Assembly, or Senate pages to find your representative.
Okay.
All right.
Thank you.
If you need some help with that, let me know.
Okay. Thank you.
All right. I guess we can move on. Thank you. Thanks, everybody, for attending today.
Thank you so much, Alan. Okay. So we have 2 presenters left. We have Marianne Emmerich, and we also have Danielle. I believe I saw Marianne on, I love her presentation that she has, the picture that she has up. Marianne, can you hear me?
Yes, I can.
Oh, there's your face. Hi, welcome. All right. So we're going to go ahead and get started with Marianne. Marianne graciously offered her time today to speak to everyone about essentially what it's like to live with HD, but also having conversation with children, what it's like being a caregiver in the house, and just some of the family dynamics. So I'm going to go ahead and pass it over to Marianne. And again, thank you for taking the time to speak today.
Thank you. So thank you so much for having me, and thank you for everyone joining and all the rest of the speakers. Everybody's been amazing so far. Alan, I don't know you. I've never met you, but I feel like I know you and I'm a big fan. So thank you so much. And you explain advocacy perfectly. So I don't know how I can share my screen. I think, Alan, you're still sharing it, so I don't want to.
You should be able to still click the green button at the bottom, Marianne.
Got it. Sorry, it wasn't popping up.
That's okay. Perfect, we can see it.
Sorry, I'm not really tech savvy, so give me a second. Okay. Wait, sorry. Okay, while I'm trying to maneuver this, I'll just give you a brief intro of myself. So my name is Marianne Emmerich. I am manager of youth and community services at the Hdsa National Office. I wear a few different hats. I am also personally impacted by Huntington's disease. So I'm giving you this presentation from a few different perspectives. So talking to kids about Huntington's disease can be really difficult, right? Just my display. Oh, okay. So when HD is in the family, everyone's impacted, and this includes children, and children being the ages. And when I talk about children or kids, I'm saying children at any age, including teenagers and young adults. Talking about HD with children may not be something that you want to do at this time, but because you want to protect your children. And we know that's important, but being honest is just as important. And knowing about the disease, children know more than we give them, than we realize that they understand or they know. So the chances are that they already know something is different about their family, especially if they have someone that's in the house that's impacted or showing symptoms. So these are just some quotes from parents that have not told or have told their children about Huntington's disease. I remember that we kept worrying about it and kept dreading it. I think it would be a little scary for them to know, you know what I mean? So I didn't really bring up a whole lot of stuff. The decision was really just to keep them in the dark, if you will, until the time came that I thought it was appropriate. My son, who's at risk, has some other challenges and alcohol issues. Eventually, he took it very hard. He was angry because I knew it for 20 years and didn't tell him. So how to start? You have all these questions: where, what, when, what do I say? How do I explain it? Especially at different, if you have children of different ages, right? How do you explain it to them? So some of the logistics of talking about Huntington's disease with a child or a young person impacted. So who you talk to, it should be the children, all the children should be present at the same time. You don't want to have one child that may be a little bit older and can understand more, and explaining it to them and having them have to keep it a secret from their siblings, right? So even if that initial conversation is very basic, you want to make sure that it's an open conversation and a continuous conversation. It's not like a one and done kind of conversation of bringing up Huntington's disease. So you want parents or guardians. It can be very difficult, especially for people that were maybe recently diagnosed with Huntington's disease or a parent that's symptomatic. So if it is challenging or too challenging to have or express it from the person with Huntington's disease, that's okay, but just making sure that it's okay that the child knows that they can go to them and have the support from them. So if a parent is unable to be present, making sure that it's a trusted adult, whether that's an aunt or an uncle, a grandparent, and sometimes the grandparent might be caring for the child. So this could be anyone in the family or in the community, where it should be a private place. It should be a space with as little distractions as possible and being very comfortable. So, you know, if you're not a family that sits at the dining room table to have serious conversations or talk about, you know, how their day was, you know, don't do that for this conversation. If you're more of a, let's hang out in the living room or go outside for a walk, wherever is your family's comfortable space, that's where you should do it. And when, you know, we'll go into why and when people start talking to children or their kids about Huntington's disease, but just saying when everyone can be present at all ages, and after learning about all the facts and the support and resources that you can, that's when the time is right. So the importance of taking time to process your own results before sharing. So, you know, some families are more open than others, you know, knowing that you're going to get your test results and sharing it with your child or a loved one, you know, is good depending on the age of the child. This is just a quote from a mother that received her results. I think telling your kids right away when you first get the diagnosis is, in my opinion, a mistake, because I think you have to allow yourself to deal with the fear and sadness and the anxiety and sit with it for a little while and process it and try to come out of the other side of it, because otherwise you're going to communicate your fear and your anxiety to your kids. And so that the only reason why I wanted to wait a little while to tell my kids is because I wanted them to know I was okay, which is really important. So making sure that you have that support too. And, you know, because just like we said, kids probably know something's going on or something's, you know, different about my mom or dad or grandpa or grandma or someone else in their life. They're going to feel that fear. They're going to feel that anxiety from you as well. So some reasons and questions to consider when you're thinking about talking to your kids about Huntington's disease. So thinking about their maturity level and their personality. You have children of different, you can't say specific age, you know, your child at 5 years old is the same as another child at 5 years old. You know, there's different maturity levels for different personalities of children. For instance, I don't have any children, but I have nieces and nephews, and we were telling one of my nieces about her grandfather that passed away, and telling her, she was like, why are we talking about, and her initial reaction is, we're talking about dying like it's a bad thing. It means the person's not in pain anymore. And she's 5. And she says this, and it was like, my mind was blown when I heard this from her parents. And then her cousin that's the same age couldn't grasp it as she did. You know, he thought, you know, grandpa was gonna wake up later on. So it just shows like the difference in how you need to approach it with different children. So thinking about if the child is exposed to someone that is symptomatic. If that is, then they're probably noticing something. Maybe, you know, somebody might have certain behaviors if they get angry easily, or if they fall often. So if that could be a reason why someone would want to start the process of opening this lines of communication with their child. Providing age appropriate information and making sure it's gradual over a period of time. So it's sort of like when, you know, you have a baby and you're trying to, you know, different foods with them. You give them a little taste here and there and see how they react. If they like it, you give them more. And so it's something similar in that conversation. And don't think this is like I said, a one conversation and done. It should be an open line of communication, and you should leave that platform for your child to feel comfortable to go to you to ask more questions. And as they, you know, mature or get older, more information can be provided. Was somebody recently diagnosed, and are there siblings of different ages? So these are just questions and things to consider, and reasons to talk to kids. Like I've said, kids are receptive and understand difficult topics faster than we realize and give them credit for. Everybody has a phone, younger, I think, now than ever. And there's more access to online information, even at school, or going to friends' houses. Even I remember growing up with Huntington's disease in my family. My mom was diagnosed when I was 10 years old, but she was sick probably my entire life. And I always knew my mom was different, but I didn't know why. I knew what Huntington's disease was because, but all I knew about it was that my grandfather and my aunt died before I was born from it. But that's all I knew. And so when she was diagnosed and she finally said she was getting tested for this only the day before, and didn't give me much information after that on that specific day, when we found out she had it or tested positive, all I could think about was that she was going to die from this. And that's all I knew. And then, you know, keeping it a secret, trying to protect us and telling us that we had to keep it a secret. You know, she was trying to protect us. My family was trying to protect me and my sister, but it actually did more harm, right? Because in school, when I had access to a computer, I would look it up. I would look at the back of a textbook, right? So making sure that you're able to give that information to them. You give them the information you want them to know, right? Because you Google something like Huntington's disease, it's scary, right? Or if you look at the back of a textbook and see the same definition that you see in every other textbook and have no idea what it means, you know, your imagination can sometimes be much worse than the reality of the situation. You want to develop that sense of trust with your child, you know, making sure that you're being open and honest with them and keeping that line of communication open. Creating a safe space for them to ask questions and express their feelings. And it's okay if during this conversation or any of these conversations you may have with them, if you're showing emotions, emotions are okay to have we have them for reasons, right? We're supposed to feel, and your child should show that, or feel comfortable rather, that it's okay to be scared or be sad about something that's going on with a loved one. That, like I said, though, also keeping that positive, those positive feelings as well, because they do feel that fear and anxiety. So making sure that you're able to approach the topic not in a fearful way for them. And enhancing that feeling of security, that they feel, they know that they are still loved and supported. So like I continue to say, this is not just one big talk, but this is a start of many conversations. listen and tackle what the child wants to know about. So it's more about listening and giving them small bits of information of what's going on and keeping them in the loop of what's going on with their loved one right now, right? And listen to what their response is, listen to their questions, and realizing that not everything's going to come up, and it might not be the appropriate time initially. Giving them all that information can be a lot. And some children might just be silent and fearful and not know and not fully understand or grasp it. But that's why figuring out different age appropriate. And I'll give you some resources at the end, specifically talking about what age group and how to, what questions that might come about. It's okay to not to have an answer for everything. And don't think you have to. It's okay to say like you want to, do some research or talk to the doctors in order to get the correct information for them if they have a question that you can't answer or don't feel comfortable answering at that moment. Like I said before, it's okay to acknowledge your own emotions and taking breaks during this conversation and leaving time for them to process the small bits of information. Using your own words and paying attention to the child's age and maturity level, like I've said. Using your own words, meaning don't, not reading off of something like, I want to share with you what Huntington's disease is and giving them a long, drawn out definition and not understanding it really yourself, right? And so making sure you put it into terms that how they can see it, when if you're telling them that mommy's sick, mommy has this illness called Huntington's disease, and using, when mommy, gets mad sometimes, or mommy has trouble, getting dressed and I need to help her. Those are things that are caused because of Huntington's disease, and bringing it into how they might understand or what's going on currently in their life. So this may be new territory to you. So the best you can do is just do your best. There's no right or wrong way to do this. These are all just tips and just observations from genetic counselors, social workers, and caregivers and parents of people that have done these conversations and have participated in studies. So why do we have these conversations? These are really hard conversations, right? But these could be more valuable than what a child's imagination could be. Like when someone, for example, a lot of people talk about when you're telling children that your parents are getting a divorce, they always say you want to reiterate how much you love the child and how much, mommy and daddy are going to still be there for you and your siblings, and it's not your fault, right? And reminding children of that. It's similar to that kind of conversation because kids will imagine, is mommy being mean to me? Like, did I do something wrong, and bring it back to them? And it might be just that they're at that age that they can't understand fully. So reiterating that information. This information can be something you can control, and like I said, not be something that they go to school and Google or go on their phones and Google. So when having these conversations, you're able to control what they know and how valuable or how certainly the resources are or where they're provided from. If there's a change in diagnosis in a loved one, these are the reasons why we might have these conversations. And it brings the child into the process of what's going on, especially if someone is symptomatic in the home or close by a loved one, and they're part of the caregiving team, and they're not even realizing it probably, right? And brings them into, you're part of this family, and we want to make you part of what's going on in mom or dad or a loved one. This is creating a safe space and a supportive communication for questions or feelings, and making sure that continues to be open. And it's helping them to find ways to cope with Huntington's disease and express their emotions. People sometimes, especially with kids, research has been done where, people that have sort of hidden it or trying to protect their children from Huntington's disease, they cope in different ways. They become angry because they don't know why their loved one is acting a certain way or changing, and they don't have reasons behind it. So instead of, going down different paths, finding and helping guide those coping mechanisms, like, being supportive with therapy or being supportive with any kind of healthy lifestyle things that they might utilize to cope. So it's important to remember to be honest, right? So like I said, you don't have to continue to give them all the information just at once, but being honest and let them know that, for instance, that there is a history of HD in the family. You know how grandma would get angry, and explain to them the best way they can and tell them what's currently going on in their family, or your family member rather, and how it affects certain events in their life. Discussing current care that might be needed for doctors, discussing what's going on right now. You don't really need to, that initial conversation especially doesn't need to necessarily be, any future or long-term discussion. Prepare to listen. It's really, really important to listen to see where they're at and what they're grasping and what they're understanding in order to guide that first conversation and continuing that other conversations down the line. Being patient and allowing them to process what's being said. All that information, just even saying that someone's diagnosed and explaining what Huntington's disease is going to be a lot. So going too much into detail on it being genetic, and that doesn't mean lying to them, but not being so concrete with those yes or no's right away. Be open to questions. Make sure you continuously during the process asking them if they have any questions and seeing. I continue to say, making sure there's future conversations. This isn't a one-time thing. Avoiding too much information and continuing to reassure that they have your support, loved one support, and outside support. And that continuing to say, like, just as much as you want to support them and provide them with maybe like going into therapy or community support, you need to do that for yourself as well, right? And providing you the right information. These are just some points to include: a simple explanation that there is a family history with HD, how the affected person's HD symptoms may affect the child's life at this current moment, reassurance that the child is valued and supported, a description of something that they can do to help, something tangible. So, this is good, especially for younger kids, giving them, you're probably, like I said, children are probably caregivers way before we even give them credit for being, whether that's even like cleaning up, maturing at a very younger level than most kids. They're going through something very different than most kids that their age are going through. So even just saying we're gonna help the person wash their clothes, whatever it might be, help mom do X, Y, and Z, just to give them some sort of responsibility, making them feel like they're doing something to help their loved ones. Or even just saying keep singing to mom or dad to make, and it gets them in a good mood and being that sort of peace in their life. Offer to listen and answer their questions or concern, and continue those future conversations. So I just wanted to mention a couple, and if anybody, and please jump in at any point, there's always tough questions that it's going to be really hard to answer. So some tough questions that you might hear from a child, a young person, is mom or dad going to die of HD? And how do you respond to that question depending on the person's age? But, being not, and it's hard to be positive in these types of situations, but, saying people live for different amount of years, right? So people can live with Huntington's disease for lots of years, decades even, right? And it's just important that we continue to encourage that our loved one, you know, gets the right care, goes to the doctor, and make sure we could do everything we can possible to help them. So those are some types of ways to answer those questions and looking more into it. So we don't know when anyone's going to die, right? So focus on how we're going to live right now. How did mom or dad get HD? So when mom or dad was born, they inherited this mutated gene, and you don't need to necessarily go into how genes or how it's passed down and how the CAG repeat number, you know, that's confusing for adults to understand and grasp. So making it minimal, saying like, you know, it is a mutated gene. They got it from their mom or dad, and that's how it's caused and how it's brought on. Am I going to get HD? So that question might come up, especially if you're explaining that someone gets it from their parent, right? And these conversations don't necessarily need to happen right away, but if it is brought up, you know, explaining that every person in an HD family has a 50-50 chance of inheriting it, but there's lots of really smart scientists and researchers working on a cure and working on treatments for our loved ones every single day, and keeping that positive outlook as well. And I can go on and on with different difficult questions, but I'm going to keep going. If anybody has any questions, please feel free. With some communication strategies that could help, especially in that first conversation, being aware of your tone and perspective. Like I said, it's really difficult to be positive in these types of situations. But making sure that you're not giving them, putting on your fear, your anxiety when having these conversations. You know, your perspective will make them feel like, how should I be looking at this? Avoid yes or no questions. Those open-ended questions are really important, making sure that they can respond to some of those questions that you may have. Don't make, and this is communication strategies, not just for in that moment, but overall, you know, remembering like we're all in the family going through this, right? So especially after that initial conversation, in order to continue that open line of communication and feeling comfort and support, you know, don't make, you know, small accusations. It's easy to get really frustrated. But remember that they're going through something as well. Depending on their age, it might come out in different ways. So avoiding those accusations, avoiding blaming, no name calling for how people are reacting, especially when having these conversations. You don't know how your child or your young person might be reacting to it. Don't generalize certain behaviors that they're doing that are based on, you know, when a child's doing might be acting out in school, and that might be a way of them coping, and remembering that these could be reasons. And when you do have those conversations, you know, opening it up to, should we be having these conversations in the school setting? The school counselors, you know, they don't want to be also like targeted or singled out in school. School is challenging as it is, just being in school, and kids are mean. So you don't want this to be something added on. Don't deny any feelings and avoid giving advice. But especially with the school piece of it, if you are going to approach the school or the school counselor, just to letting them know what's going on at home, and make sure that the child knows that you're doing that, and make it like a group decision, a family decision, that you're going to tell the school, like, mommy's going to go talk to the teacher to let them know, but it's just going to be between you guys, not, it's not going to be somebody being shouted out in school and making them feel uncomfortable. So this is just a quote from someone, from a young person. I think they did a really good job of making me feel like it was something that was okay to talk about. You know, people are so often scared to talk about it. And, you know, just from personal experience, the initial conversation after my mother was diagnosed was that I had to keep it a secret. And at 10 years old, all I could think of is, you know, you're an extremist and you can't, I couldn't really comprehend what that meant. And they were just trying to protect me. But in actuality, I didn't talk about it at all. I lied about things throughout school because when, you know, when my classmates or friends asked me like, why isn't your mom at home? I would lie and say like, oh, she's a busy doctor in the city. Meanwhile, she was in a long-term care facility. And I didn't share it with people. I didn't have a support network of my own. I felt like I had to keep it in. And I'm not saying that I know they were just trying to help, but it took me a long time to be okay with talking about it. So making sure you build your own support network along with sharing that with your kids, right? So sometimes people feel comfortable with family members. Me personally, I didn't. I felt like I needed to be strong. My mom was a single mother with just me and my sister. So I felt because I was the oldest, you know, when she was sick and I was caregiving for her way before she was even diagnosed, I felt like I had to be, you know, put my, you know, mom hat on or put that hero hat on and be strong for everybody else. So I didn't feel comfortable talking to my sister about it. I didn't feel comfortable talking to my outside family members like my aunts or uncles about it. It wasn't until I actually got involved in the community after my mom passed away that I finally felt comfortable talking to other people outside of my family. So making sure that it's okay to let them know that it's okay to talk to people outside the family if they're more comfortable doing so, and providing that support network for them, whether that's, you know, friends or outside of the house family members, or even people in the HD community. Everyone here, if you're involved locally, local chapters, if you've gone to convention, you know what it's like to be, or even a support group. There's something different than I can't even explain it, but when I met the first person outside of my family that was impacted by HD, I never felt more close to somebody in my entire life. I thought I was close to my, you know, friends that really didn't even know about my personal life. And I felt more comfortable with a perfect stranger because they just understood what I've gone through, understood what I'm going through. And, you know, there's something about that. So if you're not involved in your local community, and I hope everybody is because they're here now, even just being here and being present and open to education days or support groups or going to your local center of excellence, that's just a huge step. But yeah, so looking into that extended family, friends, teachers, there's people in your community that can definitely build that network for you and your child. Making sure that you build that same team for yourself as either the parent with HD or as a caregiver, and being a model for your child and reminding them about self-care and how it's okay to ask for help or support. So being a young caregiver, being a caregiver at any age for a loved one, for a parent, for a spouse is hard, right? It's something that we're not supposed to be doing. You know, it's like a role reversal, especially for children. And you're taking care of your parent, you're, you know, making meals, you're helping change them, you're feeding them, you're making sure you do your homework or your sibling does your homework. So all of these different activities that it's, you know, maybe not what's norm, right? But having these conversations, right, earlier on, makes young people realize like Huntington's disease is part of their normal life now. And that's why it's so important to start these conversations earlier on. So it's not something to be feared or something to be scared of and not feel like they can talk about it or have questions about it. And so they don't have that maybe feelings of guilt or resentment that they might have for helping more around the house or caring for loved ones. So it becomes difficult for, especially in the teenage years and young people and children, but balancing different aspects of their life with school, dating, even whether or not they want to leave home, right? Especially in that teenage years for maybe college. And they might feel guilty. There's a lot of guilt. There's a lot of anger too in that. So ensuring that, making sure that they take time off to, you know, do what quote unquote is normal for them or for them at that age. It is hard though. And this is in like a perfect world, right? If your kids are caregiving and you have a spouse that has Huntington's disease and they're at home and you're caring for them, they're caring for them. But sometimes that's not like the perfect world. Sometimes it is, you know, a single parent or, you know, needing outside people or not being able to have the time for them to go out and, you know, live a normal childhood life. And so just trying your best to ensure that they take that time, even though that might be not as realistic at certain times, but even just showing understanding for that and saying like, I know you had to miss, you know, your prom, or, you know, you couldn't join baseball or Little League because, you know, we don't have time for that because we have to care for mom or dad, you know, just reassuring that you understand that this is hard for them. So these are just some emotions that you might be able to understand and feel as well as caregivers or loved ones of somebody with HD or somebody that's going through HD or with a diagnosis or symptomatic. But these are some feelings that you might feel, and you have to know that they're all okay. So here are just some resources, especially for young people. Through the Huntington's Disease Society of America, we have the National Youth Alliance, and the Huntington's Disease Youth Organization is an international resource, but has great, along with the NYA, they both have great resources on their websites with talking to kids about HD, and just other things that go along with being young and or a youth or a young adult in the HD community and what that looks like. And there's a book called Talking with Kids About HD that you could download PDF on the Hdsa website. And there's a few books as well that you can find on there about talking to kids. And these are just some other resources that in the community that are really important to be a part of, no matter your age, right? And definitely getting people involved in those youth services. I found the NYA when I was in my mid-20s. I wish I found it. I wish I knew about it when I was younger. And that's probably why I got so involved. I jumped in head first when I found it because I wanted to make sure that no one felt as isolated as I did growing up. Despite having an amazing family, despite having lots of support, I felt so isolated, and I thought I was the only person in the entire world that was dealing with this. And I realized when I did find the National Youth Alliance that I wasn't alone in this, and it definitely changed my life. So being a part of this community, although challenging, and I wouldn't wish it upon anyone, it's brought so much to my life, and I've seen it bring so much to other people's lives. So I think I might be past, but anyways, does anybody have any questions? And thank you so much for having me. I'm gonna just stop sharing so I can see. Thank you so much.
Thank you so much, Marianne. I really appreciate that. I think it's a really important yet sensitive subject, and it's something that we often see in the clinic, and I feel like I'm seeing it a lot more frequently now that you know, a lot of family members are coming looking to get tested, but are also planning for families. So this was extremely helpful for me, just to have that perspective from you. And, you know, I hope it was really helpful for everyone on the line, because I know it impacts everyone in some way. So this is very good. Thank you. I appreciate it. All right, so we're going to go ahead and transition into our last speaker, Danielle. Hi, thank you. I see you. Welcome.
Hi, thank you.
Yes, I'm so happy you're here. So Danielle, it's my understanding that you are the are you the recreation activities director at Citron?
So no, I am the recreation therapist for the neurocare unit.
Perfect, perfect. Thank you. Okay, so I'll hand it off over to you, and we will wrap up at 1:45. I know we're a little over, so if you need a little more time, we can still have enough time to close out before 2.
Okay, perfect. Can everybody see the PowerPoint? Maybe?
Yep, I can see it.
Okay.
Yep.
So a little bit about me. My name is Danny Barcombe-Bazansky. Everyone calls me Danny. I graduated from Utica College in 2013 with a bachelor's degree in therapeutic recreation. And I have been at Citron for the last 4 years as the recreation therapist on the neurocare unit. And that neurocare unit only admits patients with Huntington's disease or ALS. So rec therapy, this is a big, long definition, but to make it simple for you guys, rec therapy is basically using anything that someone would find fun or that they would use in their leisure time and use it as a means of therapy to work on whatever goals they may have. So the definition of leisure time is anything that you would enjoy doing in your free time. So it's not when you have a moment to clean the house or throw a load of laundry in. It's something that you enjoy doing for yourself. So I'm going to talk about a couple of our biggest programs at Citron. Bingo is a huge hit, and the typical person would look at bingo as it's just a fun game, you know, to get together with your friends and maybe win a prize or two. But as a rec therapist, I see it as we're working on your fine motor skills. Can you pick up the chips and put them on the numbers? Or if you're using a dauber, can you hold that dauber, or do we need to adapt that for you? You also work on number recognition and letter recognition. I've noticed in my last 4 years, as someone with HD progresses, they have a very hard time recognizing numbers, especially when it's like, say, a G54 and you're dealing with 2 numbers there to try to create one bigger number. So that's something that we work on. We also work on recognizing the letters of BINGO and realizing that B14, 14 will only be under B, it won't be under O or I. We also work on understanding concepts. So people need to know that we're playing a game of straight across. So 5 in a row could be straight across horizontally, it could be up and down vertically, it could be diagonal either way. And then socialization, which a lot of people don't realize that therapeutic rec deals with socialization, but a lot of the residents, when they get admitted, they tell us that they're most excited to socialize with people that are like them, that enjoy the same things as them, because while they were at home, they were very isolated. So that's something that we try to incorporate in all of our programs at Citron. The next one is happy hour. And a lot of people will laugh when I tell them that we have happy hour every Friday, but we do. And people normally see happy hour as just loud music, socializing, drinking, having a good time. But in rec therapy, you have that key socialization again. Also music therapy. I know when we were talking about the, I don't think she was a speech person, but she was talking about swallowing and stuff. She was talking about how important music can be. And music is a huge key with HD. A lot of people relate to music. And even if you don't have HD, there's songs out there that you relate to and you listen to music every single day, even if you don't realize it. So music therapy is very big for us. Also memory therapy. You know, our residents aren't typically older like a typical like nursing home population. So our youngest is actually only 38 and our oldest is 80. So a lot of our residents are in their 40s and 50s and 60s. And when you think about that, anybody out in the community would be going to happy hour. Their kids would be grown up to take care of themselves, and they would meet friends out at a bar. So we want to normalize that, and that's where normalization comes into play. We want to make them feel as normal as possible, even though they are in a facility, and that's where they have to live right now. The last one I want to talk about, which many people don't know that we have, is pet therapy. We have a standard poodle who comes in typically before COVID. She would come in twice a month. Now with COVID, she comes in whenever she can, because as we know, whenever there's a positive case, the facility shuts down and we can't have visitors. But pet therapy, a typical person would see it's a cute dog, it's probably soft to pet. Whereas rec therapy, we notice that there's huge emotional comfort in pets. Whether you had a dog at home or a cat or any type of pet at home, you get that emotional comfort when you see the dog again. Sensory stimulation to pet that dog and to hug it, or maybe it'll, give you a kiss and lick your hand or whatever. That's huge for them as well. Memory therapy, being able to remember their dogs or even past dogs. And it gets them to talk. And then connection, a lot of our residents won't come to, let's say, like every program, but when the pet therapy dog comes around, they want to see that dog because they made a connection. And dogs are they're so amazing as animals that they know who needs maybe more time as a resident, in that maybe that resident is just really stressed right now. And so that dog will make sure that they give that resident the comfort that they need. So here's how we engage our HD residents. So all of my key points start with A's. So the first A is approach. Approach is literally everything. If I can go room to room and ask everybody, do you want to do this craft? Do you want to come to bingo? Do you want to come to happy hour? But I'm giving them an opportunity to decline the invitation. So instead of just saying, do you want to? I say, hey, let's go to happy hour. Let's play a game. Let's go for a walk. They don't recognize right away that there's an opportunity to decline, and they're way more interested in coming because you're saying, let's go do this, instead of, why do you want to do this? So that would be my first advice, is just approach them as, let's go, let's take a shower, let's play a game, let's do whatever it is that you're trying to get them to do. The second A is attitude. So along with that approach, you really have to be positive and happy and excited to do whatever it is you're trying to get them to do. So if you're trying to get them to come out to play a card game with you so that they're not in their room all day long, be excited for that card game. Pick a card game you both enjoy and say, hey, let's come play this card game. I've been waiting to play it all day. I really think it'll be a fun time. And if you're excited, they'll start to get excited. A lot of time at Citron, I have the staff, so like the CNAs and the LPNs, I try to get them to talk it up before the program. So if we're having a birthday party, or we're having a happy hour, or maybe a craft that not many people would want to do, I have the staff talk about it maybe at lunchtime or while they're providing care, so that it's getting them excited about it. And when I come around to say, hey, let's go do this craft, it's going to be great. It's fall. We're going to make, leaf paintings. I think it'll be a great addition to your room. They're also excited for it because they've been hearing about it all day. So definitely approach them with a positive attitude. It's key to know that if they know you're not excited to do it, they're not going to be excited to do it either. You have to show them that you're excited about whatever it is you're about to do. It can be as mundane as, one of the examples later in the presentation is taking a shower. It can be so mundane as taking a shower, but if you're excited, then they might be excited. The third A is ambition. So here's that shower example. Sometimes when none of the other tactics worked, you just have to find out what motivates your loved one. Whether it be candy, I know that was an example earlier in the day, or maybe a non-alcoholic beverage. We use a lot of those at Citron. Maybe going outside for a walk, whatever it is that will get them excited. Sometimes you need to know what that is. So at Citron, we have incentives when we are trying to get them to do something important, such as a shower. I personally don't necessarily use incentives for recreation unless they're like going down into a deep depression and we're really trying to get them to engage with other residents. But we do use non-alcoholic beers for showers quite a bit. A lot of times when the residents come to us, they haven't taken a shower in who knows how long. And it's for a variety of reasons. Sometimes they just have too many falls, so they don't want to fall anymore. So they know that the shower is slippery, so they won't take a shower. Other times they don't have anyone to help them take a shower, or they might forget how to take a shower. So when they come to us, it's very important that sooner rather than later we get them in there, just so we can get them cleaned up and back into the routine of taking care of themselves. And a lot of times we have to use NA beer for that. Or if I've also found a non-alcoholic wine that we use. As a little background, our residents, if the doctor prescribes them alcohol, they can have a certain amount, but a lot of our residents with the medications they're on, they can't have a lot of alcohol. So we use NA beer, we use NA wine. We've gone as far as filling up an empty tequila bottle with water, but it still smells like tequila, so a lot of them think it is. So ambition and incentive is huge when it's trying to engage them. So the last day is adapting and modifying. This is a big, it really does depend on what you're doing. A couple examples. Card holders for card games. A lot of our residents will tell me when they first come in, well, I used to love to play cards, but I don't play anymore because I can't hold the cards. And as a rec therapist, I don't see that as an excuse. We just get a card holder for them. And all it is it's a little 1x4 piece of wood with a slit in it. And they can put their cards there and it'll hold them upright. So maybe all they have to do is pick the card up and lay it down. A lot of times we do provide hand-on-hand support for card games. If maybe their chorea is too significant to pick up the card and put it down, we will help them put that card down. And it just allows them to still be involved. And the biggest thing is we show them that they still can do the things that they love, because unfortunately when they come to Citron, they're not leaving, they're there for the rest of their lives. And me as a rec therapist, I want to make sure that they're still able to do the things that they love while they're with us. And it also depends what stage of Huntington's disease they're at. Some people in the beginning stage might not need as big of modifications as somebody end stage or mid stage. So just as a review, the 4 A's of recreation are approach. You have to make sure that you ask them, let's go do this, instead of saying, do you want to go do this? Your attitude, you have to be super excited about whatever it is you're doing, taking a shower, going for a walk, card games, board games, even if it's just listening to music or singing along to music. If you're excited, they're going to get excited. Ambition, finding out what drives them, what gets them to wake up in the morning, what are they excited about, and then using that to your advantage. And then adapt and modify. So I didn't know if anybody had any specific examples that they would like me to. I know that last slide about adapting and modifications, if there's anything maybe your loved ones want to do that you need to adapt and you'd like my input, or if you guys feel more comfortable, here's my email at Citron and my phone number at Citron. If you would like to just reach out to me that way. I know that was a quick presentation.
No, this was really helpful. Thank you, Danny. Really great stuff here. And I think it's totally relevant, you know, not just in a setting, not just in like a long-term setting or a neuro setting, but it's very relevant for folks in the home as well. So I appreciate your time and thank you.
Yes.
So at this time, we did it, everyone. I think we had a really great day. I hope you took a lot away from this today. I know it was shortened. Next year, we anticipate being in person and having a longer day. But you know, we really tried our best to keep everyone engaged. And so again, just so thankful for our speakers, everyone's time. This was all, you know, volunteer. Huge thank you. If everyone could give a round of applause to Francesca, our IT coordinator, because she has been hustling every couple of minutes, just trying to make sure that the technology doesn't fail, screens don't drop, calls don't drop, and she's doing it from California. She's a former colleague of mine. We used to work together, and she's just simply the best. And, you know, I reached out to her for help, and she didn't even bat an eye and said I would absolutely do that for everyone. So thank you so much, Francesca.
Thank you, Francesca. And I just want to share a thought with Danielle. Thank you. One of the things that I learned when I tried to engage my daughter in doing something together at Faircliff is me to show more enthusiasm. So yeah, that was good advice.
Definitely.
You know.
All right, everyone. Well, I hope you have a really lovely weekend. Stay safe, be well, and I'm sure at some point soon we'll all be in touch. I'm going to go ahead and get some of the resources together that I promised to send out. Before I sign off, I do want to let the team know, because we were a little pressed for time and due to availability, we weren't able to have Kara Bolson-Arcurai on. She's a behavior specialist and a licensed creative art therapist, as well as a board-certified dance movement therapist and a regional trainer. So a lot of experience there working with movement. And she shared a really great video with me regarding dance and movement therapy and how it can benefit individuals with Huntington's disease. So I'm going to go ahead and share that with everyone. It's going to be a media clip. I don't know if it will open on your computers. I'll do my best to send it in a file that you'll be able to open easily. But again, if you're having issues, just let me know on the side. And so on that note, I'm just going to go ahead and close out. And thank you again and have a lovely day.
Thank you, Teresa.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.